analysis stage, and it also allows us to sequence other types of genetic material such as RNA. Third biggest advance is tissue sequencing. That's where we take DNA from different tissues, and we can take, for example, DNA from blood or lymphocytes, compare that to DNA taken from brain, for example, an epilepsy surgery specimen, and we can compare them to see if the variant or the mutation is present in the germline or is tissue specific. I'm going to focus on 4 malformations to highlight some of the advances in the genetics of MCD. Listen carefully: PMG, dysgyria, and cortical dysplasia. So listen carefully is a thickened cortex with decreased gyration. In terms of phenotyping, quite some time ago, I think back in 1997, people from the Dobbins group appreciated that if the malformation was more severe posteriorly, that's associated with LIS1. If it's more severe anteriorly, that's associated with DCX. 4 genes were identified causing listen carefully between 1993 and 2007. But since then, there have been quite a large number of genes identified, and the acceleration has been with the use of genomics. This paper came out a number of years ago from the Dobbins group using a panel of 17 genes. They were able to identify mutations in 81% of over 800 patients. So this is an MCD with quite a high diagnostic rate. This is a figure from that paper showing the most common genes are still DCX or LIS1. There are quite a number of other genes that can cause listen carefully, as shown there, including 10 or so genes that have been identified since that paper was published. Now, a few of the pearls about listen carefully. These are pearls. I'll show this slide after each malformation. 4 main genes for posterior greater than anterior gradient: LIS1, TUBA-A1A, which can actually cause other phenotypes as well, DINK1H1, and CEP85L. It's anterior greater than posterior, think DCX or Reelin in the homozygous state. And some of the special features that might make you think of a gene would be callosal agenesis, might make you think of ARX. Reelin, there's severe cerebellar hypoplasia, and MACF1, W-shaped brainstem hypoplasia. Let's move quickly on to polymicrogyria. This is a paper that we published about 14 years ago now. This is a patient with perisylvian PMG. You see the sylvian fissure itself is abnormally long and abnormally orientated, abnormally branching. And if you look closely, you'll see the cortex is overfolded. That causes it to look thick. It's actually not really thick, it's just overfolded, which is why we called it apparent cortical thickening. And if you look very closely at the grey-white junction, you might see this stippling, which is due to microgyration, which is quite unique to PMG. Now, as you know, there are many phenotypes for PMG, most common being bilateral perisylvian, but there's many others: generalised, unilateral, and not to forget that schizencephaly is considered a subtype of PMG because PMG lines the cleft. What do we know about the etiology of PMG? We know there are both non-genetic and genetic causes, non-genetic including viruses such as CMV, and in utero ischemia such as loss of a co-twin. Genetic causes include chromosomal abnormalities on chromosome 22 and chromosome 1. There are many others. There are an emerging number of monogenic causes, including genes that can cause metabolic disorders that can be associated with PMG. Dr. Chloe Studdard and I wrote a review paper in 2014 listing all the known genes for PMG at that time. But since then, there have been many other genes that have been discovered and identified as being associated with PMG. So there's now over 80 genes. It's probably over 100 by now if we look closely. But for each individual patient, however, the diagnostic rate is still relatively low. We did a study that showed this together with Anne Janssen, a colleague in Belgium, where we had 123 PMG patients, and using a deep sequencing panel, We were only able to identify the cause in 20% of patients. These are some of the causes we found, both germline and mosaic causes. And the germline causes, many of which are listed here, most common of which was this tubulin gene. We would probably reclassify some of these now as dysarthria, which I will talk about later. One of the things that we identified was that if you have macrocephaly and PMG, chances of making a genetic diagnosis is about 60%, microcephaly about 30%, and normal-sized head only about 12%. So head size, very important. This is a more recent paper from the Walsh group where they used trio exome sequencing with PMG in 275 patients. This was not a deep sequencing study, so they didn't have the power to pick up somatic mutations very well. And they came up with a diagnosis in about a third. And the biggest group in this paper that was not in our paper was this new additional group of ion channel genes. Mutations in those genes can also cause PMG. So why is the diagnostic rate only 30%? Well, maybe we haven't discovered all the PMG genes yet. Well, that's a bit surprising given how hard people have looked. Maybe it's not primarily a cortical malformation. Maybe we need to be looking at other gene groups such as vascular genes, for example. Maybe we're not picking up all the somatic mosaic mutations. For that, we often need brain tissue, and we might need to do ultra-deep sequencing. Maybe there's a higher percentage of non-genetic causes than we've appreciated, such as vascular compromise in the pregnancy or in utero infection, such as CMV. So the pearls are that we know about 80 genes associated with PMG, but few standout genes such that the diagnostic rate from genomic testing is still rarely greater than 30%. Always think, could this be congenital CMV? Are there other factors such as calcification, severe microcephaly, white matter abnormalities? And always ask yourself, what is the head size, which may help narrow down certain gene groups. Let's move on to dysarthria now. What is dysarthria? Well, this was the first paper to use this term dysarthria from the lead author on this paper was Jim Barkovich, 2016. They defined it as a cortex of normal thickness, but with an abnormal gyral pattern characterised by abnormalities of sulcal depth or orientation, etc., etc. But you should really think of it as this, where there appears to be a cortical malformation. The cortex doesn't look thick or thin, but it's not typically PMG or cobblestone or lissencephaly or cortical dysplasia, but the cortex definitely appears to have abnormal gyration. And that leads us into the tubulins, and tubulinopathies have now been identified as a major cause of dysarthria. Now we need tubulins to form microtubules, and microtubules are needed for motile cells, such as migrating neurons, to move. This lovely paper came out in 2013 from Anne Janssen's group, showing the association between dysmorphic basal ganglia, particularly in large chordates, in association with tubulinopathies, giving the frontal horns this hooked, pointed appearance. There are other imaging features of tubulinopathies. I've already discussed dysarthria and the dysmorphic basal ganglia. You can also get midline cerebellar dysgenesis, and you can also get brainstem asymmetry. Tubulin genes are also required for axon crossing and pathfinding. Let's move on now for the rest of my talk to focus on cortical dysplasia and some of the work that we've done in our research group. What is cortical dysplasia? Well, cortical dysplasia refers to either dyslamination, which is grade 1, or dyslamination plus abnormal cells of the cerebral cortex, which is grade 2. What are the abnormal cells that you might see? You might see these large neurons with multiple branches, which are known as dysmorphic neurons, and many studies using tissue have shown that the dysmorphic neurons are indeed the seizure-generating cells. But some types of FCDs, you might also see these balloon cells, which are thought to be embryonic glial remnants and don't seem to take part in the epileptogenic process. This is the most recent classification system for FCD. FCD1, as I mentioned, is dyslamination, and there's various types. FCD2 is dyslamination with either just dysmorphic neurons or dysmorphic neurons and balloon cells. FCD3 should be thought of as FCD1 next to another lesion, such as hippocampal sclerosis, a tumour, a vascular malformation, or an acquired lesion. And then this new group was put in this classification, abnormalities primarily in the white matter, and this one in particular, which I'll mention again later, MOGI, where there's heterotopic neurons as well as oligodendroglial hyperplasia. Now, just over a decade ago, we really did not understand the causes of FCD. It was known that there was genetic causes for tuberous sclerosis, and it was also known that the tubers of TSC were similar to FCD, although no one really connected up the two very well. There were no familial cases in the literature that were FCD. There were a number of hypotheses floating around that maybe FCD was also related to abnormalities of proliferation and differentiation, or perhaps synaptic connectivity, and maybe some causes were related to somatic-specific or brain-specific mutations. In 2009, Peter Crino, who's an epileptologist, coined this term mTORopathy. He saw similarities with the pathology between the tubers of TS, focal cortical dysplasia type 2, hemimegalencephaly and ganglioglioma, and hypothesized they could all be related, knowing that tuberous sclerosis was indeed an abnormality of the mTOR pathway. And then in 2012, two groups, one from San Diego, one from Boston, used either microarray or exome sequencing to sequence brain tissue, and found with hemispheric lesions there were mutations in mTOR pathway genes. This gene emerged in 2013 as a cause of focal epilepsy, and then later as a cause of focal cortical dysplasia in the germline state. So this is familial epilepsy or familial cortical dysplasia. We published this paper in 2014, which was the first paper with pedigrees in which there were multiple family members with cortical dysplasia and related lesions. At that time, we didn't know what was coming, but familial cortical dysplasia is now well established, and it's mainly in mTOR pathway genes. Here is the mTOR pathway itself. Amongst other things, it helps control neuronal growth and differentiation. You'll see here TSC1 and TSC2 genes. You'll also see the mTOR pathway gene itself. And this gene that I just mentioned, DEPDC5, is part of this complex, together with the MPRL2 and 3 genes, as a negative regulator of growth. Now, just a few cases to rapidly go through. This patient of mine had a subtle but severe, in terms of the clinical sequelae, hemispheric dysplasia, causing drug-resistant seizures since infancy. This is some of the team from epilepsy lab and the lab side in my group. And this boy had a hemispherectomy or hemispherotomy. Some tissue was removed. We took DNA from the blood, DNA from the brain. It was FCD type 2A. We identified a variant, pathogenic variant, in the mTOR gene itself, only in the brain tissue and only at fairly low levels in the brain tissue. We published that as a case, hypothesizing that this was the cause of the hemispheric malformation. And in the same year, groups from Korea and Japan published larger series of patients also with different forms of FCD, with somatic variants in this same gene. And this is now the best known cause of FCD, somatic variants in mTOR. This work was done by Joe Sim, a PhD in our group. This interesting pedigree, these two cousins with cortical dysplasia, one fairly extensive, one fairly small, and their siblings had focal epilepsy without a lesion. After a lot of work, including linkage analysis, we identified this gene, MPRL3, as the likely mutated gene. We then sequenced 52 other patients and found 2 of them had germline variants in MPRL3, and we did some fancy work on the brain tissue showing reduced expression of that gene in the brain, firming up the case that this was the likely cause of the FCD. And we published this as a cause of familial cortical dysplasia. Let's go back then to the mTOR pathway, and here's that gene MPRL3 working together with DEPDC5 and MPRL3 as a negative regulator of mTOR. Third case, this is Wei Shun Li, the PhD working on this case, another patient of mine who had epileptic spasms, which initially came under control with medications and then recurred. We worked him up again. He had a subtle temporal lobe malformation, low on PET medially. He had an anterior temporal lobectomy. He had FCD2A. These are dysmorphic neurons. We found a germline variant in DEPDC5, which was published in a paper. And then thinking, why should he have such a focal lesion with a germline variant? We went looking for a second hit in the brain tissue. And we did indeed find a second mutation in DEPDC5, a different mutation to the one in his germline, at a very low frequency, 3.9% of reads. And we showed with other work that it was on the other allele, confirming biallelic inactivation of DEPDC5. We were preparing to publish this as the first case of 2 hits, and at the same time, Stephanie Bollac groups from France published the same type of case. And there have been multiple cases now of 2 hits in DEPDC5 causing FCD. We took things a little bit further, however, and we had 5 tissue samples from 5 different regions. Number 5 here is the uncus. The others are all lateral temporal lobe. We looked at the mutation load in each of these samples and found the mutation load to be highest in the uncus, which seemed to be the area that was most abnormal on imaging. We then asked the epileptologist, without telling him what we'd found, where did he think the seizures were coming from? And the epileptologist, Simon Harvey, said electrically the seizures seemed to be coming from the uncus or medially, which correlated well with what we found in terms of mutation load. We then looked under the microscope at all the regions and found that the uncus had the highest number of dysmorphic neurons. We quantified that objectively. We only had enough tissue to do this from 2 regions in the lateral temporal lobe, but with different mutation loads. And there was a perfect correlation between mutation load and dysmorphic neuron density in those 2 regions, suggesting that perhaps the mutations were in the dysmorphic neurons. And Wei took that further by doing laser capture microdissection, pulling out both dysmorphic neurons and normal neurons, and found that the mutation was only present in the dysmorphic neurons. And we published that in this paper, showing that second hit DEPDC5 mutations were limited to the dysmorphic neurons. Now, we just switch now to something I mentioned earlier, the new kid on the block for FCD, this entity called MOGI, where you have heterotopic neurons, but they're normal neurons associated with oligodendroglial hyperplasia. And this tends to cause a very severe early onset epilepsy, particularly infantile spasms. And to treat these patients, you often need to do very large resections because the lesions are often quite large. There's 2 imaging patterns. In the younger child, you might see this subcortical high signal in a linear subcortical pattern. But as these patients get older and myelinate, you sort of lose that and get this very broad area of poor grey-white differentiation. Now, the two groups did very large studies with large number of patients that had had epilepsy surgery. The group from Korea, using tissue and blood, were able to identify the cause in about a third, and the group from France in about 55%. So overall, the diagnostic rate, even if you have deep sequencing and you have brain tissue, is about 50% in patients with FCD. Now, just to summarise in the last few slides, there's a large imaging spectrum from FCD, going from either normal imaging to very small lesions, all the way out to hemispheric lesions. There are different genetic mechanisms, from germline mutations, particularly in the TSC genes or the members of the GATA1 complex. But more commonly, FCD is caused by somatic mutations, particularly in the mTOR gene, but also a number of others. And rarely, when people have looked, and not everyone's been able to do this work, two hits have been found, one germline and a different one in the brain tissue. This has been shown occasionally for TSC, but also for DEPDC5. So the majority of mutations, however, for FCD will be in mTOR pathway genes or in the gene causing MOGY, which I haven't mentioned yet. The gene that causes MOGY is SLC35A2. It occurs, it's been found only as a somatic mutation, therefore you need brain tissue to find it. This is a gene causing abnormal glycosylation. We don't yet know why it causes a malformation and epilepsy. So, last couple of slides, some take-home messages. MRI pattern recognition, genomic sequencing, and brain tissue sequencing have been the three most important advances in understanding the genetics of MCD. However, we still don't know the causes for the most common FCD, don't know all the causes. PMG diagnostic rate about 30%. FCD, even if you have brain tissue, diagnostic rate still only about 50%. And for periventricular nodular heterotopia, which I haven't talked about today, the diagnostic rate is very low unless it's a filament A pattern. mTORopathies can cause both FCD and PMG. There's different models of, as I've mentioned, germline, somatic, and two-hit. One gene can cause many phenotypes. One phenotype can have many genes, such as I've shown you for lissencephaly. There can be variable expressivity and variable penetrance. That can make genetic counselling quite difficult. In addition of which, carrier parents can be mosaic and unaffected occasionally. There's limits to our current sequencing technologies. Clinical testing is often low depth and low coverage and may not pick up all the mutations, particularly if they're somatic. And to diagnose somatic mutations, blood may not be the best source, and you may actually need other tissue, particularly brain tissue, or even individual neurons to find those mutations of very low mosaicism. But it's imperative on us, and I mean all of us, those working in fetal medicine, those working in neuroradiology, in genetics, and in pediatric neurology, to get the phenotyping right, to do the right testing, which sometimes will require research testing, and then using all that to try and give the best possible genetic counselling. So that's the end of my talk. I hope I'll be able to be available online to answer any questions. But if I'm not, or if you just want to contact me with any questions, that's my email address, richard.laventer@rch.org.au. Again, I'd like to thank you all for your attention, and thank you to the organisers for inviting me to speak.
Thank you very much, Professor Richard Revental. And unfortunately, he's not here now. But if you have any questions and comments, please put them in the question box. Okay, so I would like to introduce Professor Gustav Maringel. And as for Gustavo, I don't think he needs any introduction, and he's the godfather of the fetal brain. And his main field of the research are on the fetal brain, and has published many articles and book chapters. And he is a senior author of the fourth edition of the ultrasonography in the prenatal brain. Please check it out. So, Gustavo, would you please, give your talk?
Yes, thank you, Ritsuko, for the introduction. And following the fantastic lecture by Rick, I am going to move from the postnatal diagnosis to the prenatal diagnosis, and I will start today speaking about disorders of proliferation. And I put together microcephaly and macrocephaly because although they are in size very different, they have many things in common regarding their prenatal diagnosis. So you know that the old classification of malformation of cortical development speaks about malformation due to abnormal proliferation or apoptosis, malformation due to abnormal neuronal migration, and malformation due to abnormal cortical organization. We are going to speak about malformation due to abnormal proliferation and apoptosis. And here you have the classification. You can speak about microcephaly, megalencephaly, that is for me a synonymous with macrocephaly, and abnormal proliferation, and Rick spoke a little bit about that. But today we're going to speak mainly about micro and macrocephaly. Here you have another more modern classification that was published in 2022 by the group of Professor Severino. And again, now the classification is mostly based on genetics. Now, what regarding prenatal diagnosis? Small fetal head represents, from the side of prenatal diagnosis, a big problem, but also a large fetal head represents a big problem. Why is this a problem? If you have a fetus with other malformation, or you have an abnormal microarray, or an abnormal pathological or likely pathological exome sequencing, there is no problem. You know that something is wrong with the fetus, and since in most of these cases it affects other parts of the brain, you know that the prognosis is not dependent of the size of the brain, but all the associated anomalies. But why is truly a problem? It's a problem because most children and adults suffering from micro or macrocephaly are born with normal head circumferences. Fetuses with small and large head circumference are at an increased risk than those with normal head circumferences. 2.3% of the normal population have a head circumference that is bigger or smaller than 2 standard deviation. Also, there is a poor concordance between prenatal and newborn head measurements. Head circumference that are smaller or larger than 2 standard deviation are rarely diagnosed by the time of the second trimester ultrasound examination. As Rick told us, one gene may have different phenotypes, and the same phenotypes can be present in 2 different genes. Mutations in the same gene can cause loss or gain of function, meaning that a mutation in the same gene can produce also micro and also macrocephaly. And somatic mutations causing macrocephaly has been described. And as Rick told us, if you have a somatic mutation, the results of the amniocentesis will be, in most of the cases, normal. Starting with the problem of how we measure, there are different tables, and it's important that you should know that if you use Hadlock, a lot of your patients will be either have big or small heads because the standard deviation of the Hadlock curves are very thin. Today, we recommend to use the very old curves of Chervenak because there the standard deviation is bigger, so the risk of false positives either in the big side or the small size become less. Now, another problem is how you measure, and this is a quite old case. The patient was referred to me at the 36 weeks of gestation. She suffered from pregnancy-induced hypertension, and the ultrasound diagnosis in an hospital were very, very different. One of the professors measured a -4 standard deviation. The second professor after that measured -3 standard deviation. The third professor measured -2 standard deviation. And actually, when I saw the patient, the head circumference was completely normal, 32 centimeters at 36 weeks, but all the measurements were correct. Why they were correct? Because the shape of the head. The head has turicocephalic shape, so if you measure in a conus, it depends the height where you measure. So this is important to be sure that what you are measuring is the correct measurement. Now, another important thing, you see this child was born with a head circumference of 30 centimeters, and his head circumference at the age of 2 years was -4 standard deviation, but he's developing completely normal intelligence. And we know for other studies that at school age, 1.9% of the children have head circumference below -2 standard deviation, and they have normal IQ, similar to their friends in the same class. And this is because of statistics, because 2.3% are expected to have a small head and be normal. On the other side, you have here this image of a very macrocephalic child. Okay, this is a pictures of myself. I was born with a head circumference of 39 centimeters that represent 3.1 standard deviation. Now I am 71 years old. My head circumference is 61 centimeters, 4.1 standard deviation. And according to myself, not to my family, I am quite normal. Another important fact is how we define fetal microcephaly, and it's exactly the same for fetal macrocephaly. We made a study a few years ago where we found children that have a head circumference between -2 and -3 standard deviation, and all of them were developing normally when we studied them at the age of 2 to 3 years. And what is more important, 18 of 20 of these children were females. Now, following the problem, I spoke about if you perform an examination during the second trimester, the head circumference can be completely normal. As you see in this case, okay, the head circumference is growing and is normal, is not below -2 standard deviation. But as pregnancy continues, okay, there is a plateauing in the growth, and this is the head circumference after birth. Okay, that is during the last examination was -3 standard deviation. After birth is between 2 and 3 standard deviation. But what you can see is that during the last 6-7 weeks of pregnancy, the head circumference almost didn't grow. And this is the head circumference after delivery, and we found a mutation in a gene that is called a variant in a gene that is called CCND2, and and this particular mutation is known to cause loss of function. And what is very, very interesting, there was paper published with the same mutation, but what is important is that the same mutation in the same gene in another exon may cause macrocephaly, as they show in this table. You see the CCND cause MPPH3, that is one of the known genes of macrocephaly. The protein cause is a gain of function, okay, but if the mutation is in another place, and this is a missense nonsense mutation, it causes loss of function and macrocephaly. Another problem is what you need to do when you have a fetus that is referred to you late in pregnancy because of macrosomy. They come to me after a fetal brain MRI that was considered normal. The CMA was normal, but you can see that the fetus has quite large head, and here you have the curve of how the head circumference growth. Okay, it was 1.9 at 29 weeks. It was 2.7 at 34 weeks, and 1 week later it was 3.2. It was growing very, very fast, And in this case, everything was normal. Again, we have the confidence that it was normal because of the MR. Sorry. Okay, but the large head circumference, no ventriculomegaly, there was not a protruding, was not frontal bossing. Everything was apparently normal, and we decided that we need to recommend to go for exomics. And the exomics results in a VUS variant, okay? But this VUS variant, okay, was VUS because it was not previously described. But they wrote that this variants in the same gene, that is the CHD3, may cause a syndrome that for me was the first time I saw this name. This syndrome is called Snyder's-Bloch-Campau. But since the cause of the HPO, the cause that we refer the patient for exome was the presence of macrocephaly, okay? When we look in the 35 individuals that were diagnosed with this syndrome, okay, the only thing that was present that can be diagnosed by ultrasound during fetal life is macrocephaly that was present almost in 60% of these cases with widened CSF spaces. So we ask a review of the MR. Okay, this is how these individuals look, and we ask a review of the MR, and you can note here that also in the MR there was a increased size of the subarachnoid spaces, and when you look at the child, the face was a little bit dysmorphic, but nothing else. We published this case of the prenatal diagnosis of this syndrome. Was the second or third paper in the, but now there are more and more cases that has been described with this syndrome. Another important thing when we speak about the head circumference is the size of the head is different. The 50 percentile is different in females and males. During the last weeks of pregnancy, the females fetuses have a head circumference that is by mean half centimeter, meaning more or less 1 week difference in size. Now, what we have regarding prenatal diagnosis of micro and macrocephaly, these cases have been rarely reported. I look for microcephaly in the title of the paper and prenatal diagnosis. There were until now there are 156 results. But until 2014, there were only 69, meaning that most of these results during this period of time, the last 10 years, has been related to the Zika virus. Regarding macrocephaly, again, I did the same work, macrocephaly and prenatal diagnosis, only 29 results. You wrote megalencephaly and prenatal diagnosis, there are another 10 results. And if you wrote hemimegalencephaly and prenatal diagnosis, only 16 results. So you see that these cases are rarely reported, and the reason that we during the last 20 years have seen a lot of these cases is because we are a referral center. Now let's speak about microcephaly. When we speak about microcephaly, there are two different classifications, okay? But let's say that we speak on this classification, we put in one side the genetic origin, okay? And genetic may cause early onset, okay? Early onset of microcephaly is usually due to abnormal neural or glial proliferation. About microcephaly, when we speak about microcephaly, there are two different classifications, okay? But let's say that I am here myself, something is wrong. One side Hello? Okay, I can continue. So you have early onset. It can be the trisomies or microdeletions, or also in holoprosencephaly and some very rare monogenic disorders. We can have microcephaly associated with migration disorders. This is, in our practice, more common. Microcephaly with periventricular and other heterotopia or with polymicrogyria, and the case of 17p13.3 deletion. Late onset post-migrational rarely will be diagnosed during pregnancy, and here you can have the pontocerebellar hypoplasias, CASC, X-linked dominants, neurodegenerative disorders, and red-like variants, and again, post-migrational that extremely rare and rarely diagnosed during pregnancy are congenital disorders of glycolization and metabolic disorders. But again, we need to remember that in many cases, microcephaly can be acquired, and we have now the example of Zika virus, but also we have acquired infective microcephaly due to CMV. Different types of microcephaly, we can call them primary or syndromic, postnatal, postmigrational, or acquired. This is another classification that in my impression is not very important. Now, in microcephaly, consanguinity is a very important factor. A recent paper show that the yield of exomics when there is a consanguinity in the family is around 60 to 70%. And there is no consanguinity, the chances to make a diagnosis are much, much lower. And this is an example. Years ago, it's a family with consanguinity. We follow the patient every 2 or 3 weeks because they were after a termination of pregnancy 36 weeks. The brain was considered normal but small. The child, they have a child with progressive microcephaly and severe mental retardation, and you see again the plateauing. The diagnosis was reached in this child years later, and it turned out to have a mutation in the gene that is called ASNS. A few years later, we have this patient again with plateauing, and the mother was from the same family, the husband of same ethnic origin. She was after a termination of pregnancy because of microcephaly at 37 weeks a few years ago. The ultrasound was completely normal. The MRI was completely normal. At this time, we were not aware of the diagnosis in the other family, and the child was born with microcephaly with severe mental retardation and had eventually the same disease. These cases of extreme microcephaly with a simplified gyral pattern are very easy to diagnose. They appear early in pregnancy. You see here at 28 weeks, the head circumference was minus 3.8 standard deviation, and they don't represent a diagnostic challenging. This is how the child looked after delivery. He passed away very fast, and something is interesting is not that he have not a big ear, but have a very, very small head. This is another case. We saw the patient for the first time at 27 weeks, and the head circumference was minus 2.1 standard deviation. But from this moment, we were aware that something was very wrong. Why we know that? First of all, when you have microcephaly in the axial planes, it's difficult to see the brain because the sutures and the fontanelles are small or close. But after that, even in the axial plane, you see here that the occipital horns are not well developed, and there's a lot of fluid in the midline here. And again, in the mid-sagittal plane, not mid-sagittal plane, sorry, you see again, there's a lot of fluid around the brain at 27 weeks. We cannot see sulcation. Okay, the patients were not willing to go for termination, so we perform an MRI at 30 weeks that confirmed the findings. Looking again, the undevelopment of the occipital horns, and you see here something that is characteristic of fetuses that eventually will have polymicrogyria, is that you see that the brain here has a round shape, and at some point it becomes like someone cut with a knife. Okay, and this is very characteristic of microcephaly with polymicrogyria. But the CMA and the exome were considered normal. Okay, this is the examination at 33 weeks. Mm-hmm. Okay, the head circumference is minus 3.5 standard deviation, and the brain is completely disencephalic. So the fact that you don't find a genetic diagnosis doesn't necessarily mean that the child will be normal. And as you can see here, We proved it because the family was not willing to terminate pregnancy at 27 weeks, at 33 weeks, and 30 weeks. The findings are much more clear. Always look for associated malformations. And this is a case of very severe, perhaps the earliest case with microcephaly we diagnosed at 20 weeks, very small. It was at the time that we didn't measure the head circumference, the BPD. You see that the BPD was very small, and the fetus was terminated with a diagnosis of Neulaxova syndrome with an encephalocele. Remember, again, I spoke about that. Remember that we have acquired microcephaly, mainly due to infections. And this is one example of a fetus that has severe CMV infection. You see that the large subarachnoid spaces, that is due to the fact that the brain is small with the presence of polymicrogyria, abnormal sulcation, okay, and again, a wide separation between the occipital lobes. And this is another case, Smith-Opitz syndrome, and you have here callosal dysgenesis, a small cerebellum, an AV canal, and the child have the Opitz syndrome, Smith-Lemmy-Opitz syndrome, with facial edema, hypertelorism, anteverted nerves, short web neck, and ambiguous genitalia. So this is currently our protocol of a study, and again, it's very important to understand that the fact that the use of exome has become more and more common. So, in conclusion, regarding microcephaly, the most common and problematic concern is when the head circumference is between -2 and -3 standard deviation. Warning signs included associated anomalies, arrest of head circumference growth restriction, IUGR, growth restriction, and consanguinity. Below -3 standard deviation, the risk of mental retardation is around 50%. In the vast majority of the cases, the diagnosis is made during the third trimester or after delivery. Now we go to large, and size again here matters because we have this is three different conditions. You may have a large fetal head, as I told you before, and I show you, and a completely normal person. You may have macrocephaly or brain overgrowth. Before the next generation sequencing era, okay, we published a paper on the diagnosis of syndromic macrocephaly, and we have quite a big number of patients with macrocephaly that was considered isolated, and 60 of them have associated anomalies. And when we put together our data, okay, gestational age of appearance of the macrocephaly didn't reach statistical significance, and the only calculation that reached statistical significance was the head circumference during the examination, the Z score, that in group A was 2.3 and in group B was almost 3 standard deviation. Okay, almost all the children that have isolated microcephaly were large for gestational age. 68 of them have a macrocephalic parent. Most of them were boys, and almost all of them have normal development, no cases of mental retardation. There was a child with the autism spectrum disorder, and 3 that did physical therapy. One patient decided for termination without explanation. On the other side, the associated anomalies included that we expected to find, that as mild ventriculomegaly, callosal anomalies, and malformation of cortical development. We reached a prenatal etiologic diagnosis in only 5 cases, and in other 11 cases, the diagnosis was reached only postnatally. And this is one of the first case of macrocephaly capillary syndrome. This time we didn't have sequencing, we didn't have genetics, but you see a very big head. The child was born, and she's actually doing quite well, but she's extremely macrocephalic. This is another case of macrocephaly. Again, the lateral ventricle was a mild ventriculomegaly. Okay, we didn't like the shape of the brainstem. The head circumference was large. The corpus callosum, that's something that's very common in these disorders, was large, and we were also able to diagnose polydactyly. The MR shows the presence of polymicrogyria, and the postnatal MRI show again the presence of polymicrogyria. We missed by also in the ultrasound, also in the MR, the presence of this hemangioma. Okay, the postaxial polydactyly was present. The conclusion of the paper that was that fetal macrocephaly with head circumference between 2 and 3 standard deviation and not associated anomalies usually carries a good neurodevelopmental outcome, in particular when there is a family history of benign macrocephaly. Fetal macrocephaly associated with other CNS or non-CNS anomalies implies syndromic macrocephaly, and the prognosis depends on the specific syndrome and the association of brain malformation. A genetic diagnosis can be suspected based on the associated findings. Syndromic macrocephaly is usually diagnosed only in the third trimester. Usually there is seldom time for genetic confirmation. It has changed since then. An acceleration in head growth in the third trimester usually implies syndromic macrocephaly if it reaches more than 3 standard deviations. Chromosomal anomalies may present as macrocephaly. We were speaking at this time only of CMA. Underdevelopment of the operculum is a poor prognostic sign. A thick corpus callosum is frequently seen in syndromic macrocephaly and carries a poor prognosis. And this is the most severe case, and here it comes to the lecture of polymicrogyria. This is a fetus that was presented to me when I was in a congress in Singapore. The head circumference was plus 6 standard deviation with a very thick and short corpus callosum. And you can see here that the head circumference corresponded at 22 weeks corresponded to 31. And here you can see what is polymicrogyria from the imaging point of view. Okay, you see the shape of the lateral ventricle that is very abnormal, triangular, but here you see the polymicrogyria is this undulated pattern of the surface of the brain. Eventually, we spoke about polymicrogyria based on imaging, but the diagnosis of polymicrogyria is a histological diagnosis. Now, in the next generation sequencing era, okay, we need to add to our protocol the performance of exomic sequencing. Now, when to perform exomic sequencing? Okay, if you find a fetus that has a large fetal head with associated anomalies, okay, you can be quite sure that it's syndromic macrocephaly, and the performance of exomics can be delayed until after the family reaches a decision regarding termination or not termination of pregnancy. If everything is normal and the fetal neurosonography and the fetal brain MRI are normal, the exomic sequencing needs to be performed during pregnancy to reach a prenatal diagnosis. Since we have more and more cases of families willing to do exome, today we can reach the result of exome. We can reach it in 10 days to 2 weeks. This is a fetal case of 2015. Patient referred because of microcephaly, no family history, no amniocentesis. The alpha fetoprotein was normal. Early ultrasound screening normal with normal biometry. And this is the ultrasound at 23 weeks. And what you can see is a fetus with a very big head. You see that the relationship between the head and the face is in favor of the head. And the corpus callosum measured 37 millimeters at 23 weeks. That the normal corpus callosum should be smaller, at least they say smaller than 30 millimeters. That again is extremely large with microcephaly. And this is how the head circumference grow. At this point, the family decide to go for termination. And after termination, the diagnosis was of the AKT3 variant. Here we have another case at 31 weeks and 5 days. The head circumference was 2.7. At 34 weeks and 6 days, it seems that this head circumference is smaller. Again, the fetus was not macrosomic, was large but not macrosomic. But these are the findings. As you see here, the abnormal sulcation and giration of the occipital horn with a very, very large corpus callosum and the very big head in relation to the face. And this case turned out to be a de novo mutation in PIK3CA that we reach the diagnosis before termination of pregnancy. This is why we terminate. The head circumference at birth, the brain weight was plus 4.6 standard deviation with abnormal brain. Also in the cerebellum, they found polymicrogyria, and they have multiple vascular anomalies with facial dysmorphism. And here we have another case, okay, where we see very clearly the abnormal shape of the lateral ventricles. In my opinion, this is due to the fact that the corpus callosum is very big and it goes to the sides, so the lateral ventricles cannot go up because the fibers of the corpus callosum don't let the lateral ventricles to go out, so they become triangular and pointed. And here you can see the almost the complete lack of sulcation. But what's more interesting and what probably makes the diagnosis is the fact that you can see here at 26 weeks the presence of sulcation that is abnormal. This sulci and the shape of the cortex should be at 26 weeks disencephalic or without sulci, as you can see in these sides. And also this fetus has a malformation that was diagnosed by exome. And also the post-mortem examination confirmed the presence of polymicrogyria, multifocal and bilateral, facial dysmorphism, and also hypertrophy of the first two that was bilateral. Again, another case, large corpus callosum. Okay, the lateral ventricles were not dilated, and again, here you see the abnormal sulcation. Something went wrong. Okay, this is the follow-up. At 24 weeks and 6 days, the head circumference reached 3 standard deviation. The corpus callosum was well larger than the 97th percentile. The patient decided to go for MRI, and the exome was expected after delivery. Okay, this is TMR showing the abnormal brain, and after termination, we found a PIK3R2 mosaicism de novo that was present only in the amniotic fluid fibroblasts in 8% of the cases, but in the brain tissue that we perform autopsy in 20% of the cases. And this is my last case. Okay, we have this patient referred at 23 weeks because of severe brain anomalies. And here you have the finding. The head circumference was 3.6 standard deviation. It was not macrosomy. The brain parenchyma was clearly abnormal, starting from the ventricular wall to the wall parenchyma with very abnormal sulcation, with a very abnormal cerebellum. And you have here the images at 23 weeks. Okay, it's very clear that the whole brain is abnormal. Okay, there were also other findings. Was a lot of fingers, heptadactyly, was a very big thumb in the leg, and you can see here also in the 3D. And the pathology showed all the findings that we saw in the ultrasound examination. And the autopsy at this point, they were able to give us a differential diagnosis that was maybe megalencephaly polymicrogyria, maybe the MPPH1, maybe MPPH megalencephaly capillary malformation syndromes. And again, also we were very sure about that, but we were surprised by the results of the exome sequence. It turned out that this fetus has a pathogenic variant in a gene that is called OFD1. That this pathogenic variant have been non-described previous not in the clean VAR, not in the general population, and this variant may produce different syndromes. Joubert syndrome number 10, orofacial syndrome, Simpson-Golabi-Hamel syndrome, primary ciliary dyskinesis, and the phenotype was more compatible with Joubert syndrome. So when we went to the literature, it turns out that these similar cases has been published, meaning that the phenotype in the abnormal phenotype of the OFD1 gene may produce ciliary dyskinesis with a Joubert-like presentation, but also with a presentation that, in my opinion, was also very similar to the Simpson-Golabi-Hamel syndrome because of the presence of the fingers. So in conclusion, if you have micro or macrocephaly with associated malformations, consider termination, and you can do the exomic sequencing later on. If you have an apparently isolated microcephaly or macrocephaly, the decision will be based on the exomic sequencing. And a provocative statement to finish: exome sequencing for all. Today, the recent papers, also from China, also from Israel, show that if you perform exomics in a low-risk population without ultrasound findings, the chances that you will find some pathogenic or likely pathogenic variants is around 2%. They found a little bit more. I am not sure that the results are 2%, but the chances to find something are quite high. So the first tier, if the family decide to go for genetic evaluation in pregnancy, should be straight exome sequencing. Don't do karyotype, don't do CMA, go straight for exome sequencing. Thank you very much.
Thank you, Gustavo. The nice lecture and very rare cases included, and there are several questions already, that we had. However, we will have the Q&A session after Karina's lecture, so please wait for a little bit. And so the participants, if you have questions and comments, please put them in the question box. Okay, so the Karina, so next speaker. As for Karina, everybody already knows she's the top expert of the fetal brain from Tel Aviv, Israel. And Karina, with Gustavo together, published a lot of articles and book chapter. And I think she's a perfectionist, and also very thoughtful. And I always learn a lot from her all the time, and because of her thoughtful presentation and the very nice slides. And I promise you will also learn from her a lot today. So please, Nina, start your lecture.
Thank you, Ritsuko. Thank you, everybody, for being here. And Ritsuko, thank you for your words. It's a double way. So let's speak a little bit about lissencephaly and dysarthria. And I really hope that you don't get very depressed from the lecture, because it's hard regarding fetal life. And we are going to bring some new aspects regarding the assessment of these entities in fetal life. So please just let me know that you see my slides okay. Do you, Ritsuko?
Yes.
Yes, Karina, yes.
Yes, perfect. Okay. So, for the ones that do not know, I am Brazilian in origin, and I really do like football. So we are going to start, and Rick and Gustavo really have made my life a little easier regarding the background of the cortical development. So I will go straight forward to our point. And our main players regarding neuronal migration need to be understood for us to understand the complexity of the possible diagnosis, the overlap of the fetal phenotype of the different entities, and why do we find specific abnormalities in the brain in this and that disease. So the neuronal migration process is very, very, very complex, and it relays on different structures that need to be normally configured in the brain. So we have the radial glial cells, which will be the pathway of the radial migration, the microtubules, the microfilaments, actin, double cortin, and many other proteins that are very important, transcriptor factors for the axonal guidance, the normal development of the extracellular matrix and proteins that are responsible for this development, the normal development of the meninges. So the meninges would be the pia mater, mainly will be the end point of the migration, and it's very important that it's completely normally developed and no gaps in the meninges. And there are many, many other factors that are important, but these are the main ones. And whenever we have abnormalities in the microtubules, so we have a tubulinopathy, we have a dyneinopathy in the microfilaments, and double cortin. So we have different names that are secondary to the underlying mechanism of disease. So I know that, especially for us gynecologists, these names are very, very frightening, but we need to understand that. Otherwise, we won't make it into the process of the differential diagnosis. So first thing first, regarding the fetus, how can we even suspect that there may be an abnormality of migration, especially lissencephaly and dysarthria? So normally the main referral causes are ventriculomegaly, abnormal anterior complex. So although it's not part of the basic scan, but I really, really invite you guys to check on the anterior complex, presence of brain asymmetry, and if we go and check directly for the sulcation, so of course signs of delayed or aberrant sulcation. And I will abort the topic of the head circumference later. Of course, if head circumference is small, it really, really helps us to suspect. But in most cases, unfortunately, during fetal life, the head circumference won't be small enough for us to raise suspicion on an abnormality. So it's not a very, very good screening point. We need to understand the normal development of the brain. So there are different maps. We not only need to understand the main sulci when they appear and where, and unfortunately I have no time to discuss the normal development, but and most maps, they are quite alike regarding the week that they offer the appearance, so we can choose whatever you like. And then we need to understand at least our three main fissures in order to start from the second trimester scan. So the development of the Sylvian fissure, and here is this piece of art from Ritsuko showing the development in coronal views, but it's not enough for us to check on the coronal view because the Sylvian fissure it's three-dimensional, and in some cases the clue will be only in axial view, so we need to do it together, coronal and axial views, and check for the anterior and the posterior component of the Sylvian fissure. Sometimes, like you see here, 25 weeks, the anterior component is completely flat, the posterior component it's present, but it's a little delayed. This is what we call the toast brain. We learned it from this term from Daniela, and it also should raise suspicion that something may be bad. and we are going to explain why we may have difference from the anterior and the posterior aspect of the brain development. The parieto-occipital fissure as well, and the different patterns of appearance, the calcarine sulcus. So these three are very, very important and should be checked at the time of the second trimester scan. The sulci of convexity will appear later on, normally after 25 weeks. I like to say that by 26 weeks, the corona view of the brain needs to be like these four leaves clover love, and it's very like grosso modo a way to check. So we need to have one indentation in each aspect of the brain, and it really, really helps us regardless the name of the sulci. Remember that the parasagittal view of the brain, so the surface of the cortex need to be completely smooth up to 25 weeks, a part of the Sylvian fissure, the calcarine, and the parieto-occipital. We call it physiological dyscephally. This is 17 weeks. We also can check for the normal lamination of the brain parenchyma. And here we are not going to speak about gray and white matter because the neurons are going to the cortex during the pregnancy yet. But we need to check for the normal lamination. And whenever we have oversulcation in early pregnancy, it can be very abnormal, and Gustavo has spoken about that. And whether we have a smooth surface in later gestational ages, so we need to suspect on the opposite. But you will see that it's not always true, and sometimes even in cases of lissencephaly, we will see irregularity in the cortical and the ventricular surface in early gestational ages, just to make our lives a little more complicated. So we have different abnormalities of migration. We have paraventricular heterotopia, lissencephaly, subcortical heterotopia, and microlissencephaly dysgeria, and cobblestone malformations, and they are secondary to different problems. So in paraventricular heterotopia, the neurons are not even connected to the radial glial cells, so they stop and they stay there in the ventricular zone. In this group, we have a disruption of this complex apparatus that we have spoken in the beginning. So all that structures may be abnormal, leading to different types of migration problems. And whenever we have gaps in the pia mater, so we will be facing cobblestone malformations, and these neurons will over-migrate the cortex. Regarding our lecture, so the lissencephaly spectrum, we have agyria, absent gyri, pachygyria, broad gyri, subcortical banded heterotopia, so lines of neurons in between the subventricular zone and the cortical zone. And we may have the combination of frontal pachygyria and posterior subcortical banded heterotopia. It seems very easy and fine, but it's not. Why? Because in the fetus, different from the postnatal pattern, we don't really have these clear-cut shapes of the brain, especially not in early pregnancy. Thick cortex is a sentence that may be used and applied in postnatal MRI, but cannot be sensitively applied in the prenatal imaging. So we are not going to use the cortical thickness in order to help us differentiate between types. So although this is the postnatal literature, the prenatal life is quite complicated. What helps us is that lissencephaly is an exclusively genetic disease. So different from other abnormalities, like Rick have spoken before, and also Gustavo, we have genes, and now more than 28 genes that have been previously published, and genetics will help us. So if the phenotype do not, but the genetics will do so. And I don't have time to discuss further the expanding imaging and clinical classification postnatal, okay? But they use several criteria that unfortunately we don't really use and we cannot use. We don't have myelin in the prenatal life. We cannot measure the cortical thickness in prenatal life. So these criteria are not very well applied in fetal life. We can see from complete agyria. So what is agyria? Completely smooth everywhere in a gestational age that is expected to have gyration. And we can have pachygyria, so very broad sulci. And also we can have gradients. So here the anterior aspect is more developed than the posterior aspect, as you can see. Very hard to translate into fetal life. Okay, so here we have this publication resumes very nice the genes and the function of these genes and the diseases that we expect in different genes related to lissencephaly. In the postnatal life, the genotype-phenotype analysis defined in this very nice publication 21 groups with very robust phenotype-genotype correlation. Okay, and we need to learn this because we can sometimes translate it into fetal life, but we need to understand that not every sparkling wine is champagne. So delayed sulcation, smooth cortex would not be lissencephaly always in the fetus. And we have many challenges in fetal phenotyping because we cannot check other things in the fetus. These phenotypes, like Ritsuko said, the ever-evolving brain. So they are evolving throughout pregnancy, and sometimes not even in late pregnancy, we can define the classic phenotype of a specific abnormality. Genes may have variable penetrance, although in lissencephaly is less important. Most of the genes, they have a complete penetrance, and it really, really helps us. And also, we need to remember that the phenotypes may be very, very non-specific. So whenever we have an agyric fetus, okay, here we have the abnormals, and here we have the normals for comparison. This is a publication from Edwin Corello from France. And it would be easier for us, maybe not at 20 weeks, but later on to know that something very, very, very bad is happening here. So let's see some cases using ultrasound. Again, 28 weeks, completely smooth, looks like 24 weeks. This is the control for comparison. So we know that something very, very bad is happening here. Can I tell this is LIS1, this is DCX, whatever? No. And then I will check for associated abnormalities for the fetal sex as well. And we should do a broad evaluation in order to get into the gene. But what is important in fetal life is to suspect on the delayed sulcation and then check the fetus, because these diseases are very, very, very severe, and the prognosis is bad, and normally the survival is very, very low during infancy. So this is LIS1, 23 weeks. We see that the Sylvian fissure is abnormal. We see no parieto-occipital fissure. And again, don't be misled by the ventriculomegaly, which is mild, because mild ventriculomegaly may flatten the parieto-occipital fissure. Indeed, it may. But we need to remember and then to check the other fissures. No calcarine, no parieto-occipital, very, very flat, 17 weeks Sylvian fissure. And here we see what we can call the H-shaped brain, which is postnatally very, very related to the LIS1 gene. Okay? So although we are speaking about an agyric brain, but we see irregularities in the periventricular area, and these are very, very nice pictures from my friend Mikhail Brusilov. Here we see also the lamination is completely abnormal, blurred. We don't see the regular pattern of the lamination, although we see the cortical layer here, which it appears. So we cannot measure it. It does not help. If we check this cortex in the microscope, it would be very, very thick, four-layered cortex, and very disorganized. And if we associate these findings with abnormal facial findings, so we will have the Miller-Decker syndrome, which may appear on two mutations in the LIS1 gene or deletions in the chromosome 17. And here we have other cases to show you. This is a gene variant in the PAFA H1B1 gene, which is the LIS1 gene. Here we don't see a very severe Sylvian fissure. The fetus was referred by mild ventriculomegaly in the community 11. In our case, it was not severe, and the cerebellum was normal. And here by this axial views and by the midline view, we couldn't suspect an abnormality. But here we see a subtle abnormal sulcation, especially in the frontal area. The posterior area was more developed. See the Sylvian fissures that are abnormally developed. Again, Karina, you are completely crazy. It's so hard to tell. Yes, it is. Okay, and if I try to measure here the length of the sulci like they do postnatally, does not help us. Okay, but the anterior complex is a very good clue. You see that the parenchyma is very, very, very thick, so there is a lot of brain. And the cortical thickness, again, cannot help us. This is the MRI. In the MRI, we can see better the gradient, so the posterior aspect is worse than developed than the anterior aspect. And in this fetus, we saw white matter heterotopias in the pathology, white matter and subcortical nodular and laminar heterotopias that we are not able to see inside the parenchyma of this fetus many times. So it's very, very frustrating during fetal life, but this is what we have and we need to deal with that. Again, in postnatal life, we can really, really associate. This is the H-shaped brain regarding to LIS1 and DCX and ARX and many, many other patterns, but we are not able to do it specifically prenatally. Sometimes we see this H-shaped brain, 24 weeks, associated to a very, very, very small brain, and this is microlissencephaly, variant in the renin gene, and this is microlissencephaly Norman-Roberts syndrome with also specific facial findings. But if we check 3 types of lissencephaly here, we can tell that these are H-shaped brain around 24 weeks, and each of one of them is related to a completely different gene. This is, I think, the most H-shaped brain that I have ever seen, and this is not LIS1. This is ankyrin, which is not even a specific lissencephaly gene. So beware of specific postnatal patterns, and we need to remember that we need to compare to do a broader genetic evaluation. Another disease that may appear with a JARA early in pregnancy is cobblestone, which was previously called LIS2. And we know that this is the Walker-Warburg, and this is a cobblestone malformation. But in these cases, the parenchyma, not cortex, will be thin, okay, and normally associated with a ventriculomegaly, abnormal brainstem, severe cerebellar hypoplasia, and abnormal echogenicity of the parenchyma, extracerebral layer, and other findings that we may see. I'll take a couple of minutes more, then we enter this JARA and we finish. But something interesting that I want to show you is the ARX. The ARX also postnatally very clear phenotype, an X-linked lissencephaly with abnormal genitalia and callosal agenesis or severe dysgenesis. This is the motto of ARX. But the 2 cases of ARX that we have presented earlier in pregnancy with irregular ventricular walls, that it really looks like polymicrogyra in early pregnancy. Never I would say that this fetus has lissencephaly, okay? But so there is much more that we need to learn about the fetal phenotype of these abnormalities, especially in the early second trimester. But we can suspect, and we did, that something is very wrong with this brain because the shape of the brain is different from the expected at this gestational age. And This was a twin pregnancy that was selectively terminated, and it turned out to be an ARX gene. Another male fetus, callosal dysgenesis, callosoagenesis, very abnormal sulcation, abnormal genitalia. We thought and we suspected that it's ARX, but it turned to be trisomy 18. Okay, so remember, common things happen commonly. Again, our fetal phenotypes are so non-specific, and we need to remember that. Regarding this gyra, so this gyra, differently from the lissencephaly, because lissencephaly, we have specific genes, and we go to the microscope and we see the thick cortex, very disorganized. So it's a quite well-defined disease regarding the diagnosis. This gyra is the new kid on the block, like Richard said, regarding the malformations of cortical development, because it's everything that we cannot fit elsewhere. So the cortex may have variable thickness. The boundary between gray and white matter postnatally is smooth, and there is an abnormal gyra pattern with irregular depth and orientation of the sulci. Very, very generic. Okay, so I like the second better. If you cannot fit it in any other definition, so it's probably this gyra, until we learn more about these abnormalities. And the main entity of this gyra is the tubulinopathy, the tubulinopathys, because it's an heterogeneous group of diseases that present abnormalities in the whole brain, because the microtubules, they are in everywhere in the brain. So if we have an abnormal microtubule, we will have brainstem, cerebellar, and supratentorial abnormalities in every aspect of the brain. And they may mimic lissencephaly very well, especially in the severe form. So there are many genes. There are the most severe phenotypes, and there are the milder phenotypes. The most severe phenotypes, they will present very, very smooth, but in tubulinopathies, different from the lissencephaly, we can find specific patterns in morphology that will suggest, okay, this is tuba, and you go and you check and you find. So we see a brain asymmetry. Check again for the anterior complex is very, very important. We will see irregularities in the interhemispheric fissure. We will see, and this is very early gestational age, 24 weeks, but we can see asymmetry in the shape of the anterior horns, asymmetry in the size of the hemisphere as well, and in the development of the sulci. Corpus callosum will be affected in a more severe or a less severe way, as well as the brainstem and the cerebellum. In TUB A1A, everything will be very severely abnormal. This is a genesis of corpus callosum, 24 weeks, no Sylvian fissure at all. And here the head circumference may be a little small, but not microcephaly. Most fetuses with tubulinopathy and lissencephaly, they won't be microcephalic in pregnancy. They will only be microcephalic later on. So it will not help us. Again, abnormal shape of the anterior complex, irregular interhemispheric fissure, abnormal shape of the basal ganglia, and abnormal brainstem and cerebellum. So TUB A1A is more severe, as you see here. So it's very hard not to understand that something is happening, because the associations are very, very clear. And what we learned about tubulinopathies is that, differently from what we previously thought, that if the fetus has one MCD, it can only be one MCD. In tubulinopathies, everything happens together. And this is the case of TUB A1A with abnormal basal ganglia, abnormal capsula interna, abnormal shape of the lateral ventricle, pachygyria, abnormal Sylvian fissures, and you see here, abnormal shape of the lateral ventricle, abnormal hippocampal structures, places with completely normal appearing cortex, other places with thick irregular cortex, which would be lissencephalic, and places with heterotopic of all types, nodular and band heterotopias of all types, and also places with polymicrogyra. So in tubulinopathies, because the problem is very, very basic in the brain development, different types of malformations of cortical development can coexist in the same fetus. There are milder tubulinopathies and I think TABB3 would be the best example for that. And then the findings may be milder. But that pattern that I showed you before, it would be very, very good for us to suspect on the presence of a tubulinopathy. And this is our latest publication on the spectrum of the abnormalities in mild tubulinopathies. Remember the anterior complex, remember the irregular interhemispheric fissure. Even in axial views, it will help us. This is a 34-week fetus with an irregular interhemispheric fissure. Here, the findings are very, very mild. Brainstem is also asymmetric. There is mild ventriculomegaly. But if you remember the features, check on the shape of the anterior complex. You will be able to suspect on these abnormalities, even in early pregnancy. To finish, although tubulinopathies are the main representative of this gyra may appear in other diseases as well, and this is a female fetus with L1CAM mutation. So we will find more and more axonal guidance disorders that will present again with the gyric pattern. So we see dislocation. Dislocation is very abnormal, but we cannot tell a name. So remember the diagnosis of this gyra. To finish, so how can we screen for lissencephaly and this gyra? We need to remember our dislocation reference map. We need to remember that many cases will have very, very thick parenchyma during fetal life. We are not going to measure the cortex, or very thin parenchyma if we want to compare to cobblestone cortex. The lamination will many times be blurred and abnormal to the gestational age. Check for the presence of asymmetric brain. Check for the anterior complex. The extraaxial space, when the volume is reduced, will be enlarged, different from the cobblestone abnormalities. Check for the presence of associated brain anomalies, and the extra findings will then help us sometimes to refine the phenotype and then to do a phenotype-genotype correlation. So facial dysmorphism, Miller-Dicker and Norman-Roberts, genital abnormalities in ARX, hands and feet in other cases of this gyra, L1CAM from tubulinopathy. And remember that the head circumference will not be a very good marker. Thank you very much, and I'll be here for to answer the question. Thank you.
Thank you very much, Karina. It happened, but my video cannot open. Thank you very much, Nina, and
now we are seeing you.
Okay. And thank you very much. And we would like to have the question and answer time right now. And we have Gustavo and Nina here. And also, we have the, especially, the Ravi Chawi is coming from Germany. Ravi, you can show up. And we have several questions from the audience, and I'd like to select some of them. And the first of all, which is better, the more specific measurement of the small head, BPD, HC, or transcerebral diameter? Is it the HC, right, Gustavo?
Gustavo, you're muted.
Please unmute.
Yes, you are correct. The head circumference is is the most important one. But again, if you perform a examination of the brain, you need to measure also the BPD and also the TCD. And many times the TCD can give you a clue regarding the cause of the microcephaly because can be associated with pontocerebellar hypoplasia or cerebellar hypoplasia, making these things worse.
Okay. And is it easy to pick minor cortical malformation in routine scans from India? How do you think, the Gustavo, Nina?
Sorry, I didn't hear well.
Okay. So is it easy to pick minor cortical malformation in routine scans?
No, it's not easy at all. Very, very, very hard. Again, if we do a very, very dedicated scan, so sometimes we have some clues, but that's why it's so important to check if we have an opportunity to check the fetus later on. And I know that there are many, many limitations also regarding the law in different countries and access to more exams. But here in Israel, we are fortunate to have the possibility to see many, many patients in the third trimester in order to have then a more significant clue that something abnormal may happen. And it's quite a limited access when we are in very early pregnancy.
Gustavo?
Evidently, it depends on many factors. Your equipment, how much time do you have for the examination, what is your experience. So the issue is to be aware that when you see something that seems to you different or abnormal, to go for a more dedicated examination or to refer to the patient to a place of expertise. Okay, let's say that you have a suspicion there's facial dysmorphism or abnormal genitals, or the lateral ventricles are mild ventriculomegaly, but you think that everything is normal. The midline is not straight. You don't see the corpus callosum. There is a lot of small facts or things that need a more detailed examination. But if you need to perform the examination in 3 or 4 minutes because there are 100 patients waiting for you outside, the chances will be quite low.
Yeah, actually, I think the usually routine scan is meaning the transabdominal scan.
Yes. When you perform a transabdominal, I always recommend to go to perhaps what is the most useful paper regarding diagnosis of cortical malformations. Is a paper, 2 papers that were published in 2004 by the group in Toronto, and Stoys and Fong. And by adding 3 seconds observation of the Sylvian fissure and the parieto-occipital fissure to see the diamond shape of the parieto-occipital and the shape of the Sylvian fissure, you will be able to make a diagnosis. But again, it's important to remember that all these fetuses in their paper have mild ventriculomegaly. So there was something else. But look at the parieto-occipital in the axial plane, transabdominal, and if something seems to you wrong there, again, go for a more detailed examination or refer the patient to a center of expertise.
Ritsuko, I want to add something and I will link to Rabbi because I'm very happy that Rabbi is here. That's something that I really like in his lectures and I will address. Anterior complex. This is the catch. Again, together with the Sylvian fissure and the parieto-occipital fissure, which are very important. I think this is the simplest thing and the penicillin of the fetal neurosonography because it is a game changer. It will help us if you check on the shape of the anterior horns, the regularity of the interhemispheric fissure, and the periventricular area around the anterior horns. You will be able to raise your detection rate a lot regarding heterotopias, regarding brain damage, regarding milder malformations of cortical development. So I think if we can say something very easy in axial plane that is a game changer, it's adding the anterior complex to the Sylvian Fisher axis in these fetuses. And the link with Rabi. Rabi has amazing lectures on this morphology and on the face. And more and more, I think in the last year, many diseases that we have suspected only because of the philtrum and the nose and something different in the eyes or the ear. So the importance in specific groups of MCDs to add the facial dysmorphology, especially later in pregnancy, because it becomes clearer in order to suspect on abnormality. Thank you, Ravi, for being here.
Yeah, thank you. Yeah. Hi, good to see you again, my friends. So actually, I was supposed to be in the background, but Prashant wanted me to jump in. So I'm sorry, I'm not shaved, and it's Sunday. I'm sitting at home. And anyway, so let's see what I learned today are several things. One of these is what we are doing. We are doing a basic scan on a BPD as usual. And we learned now, of course, to implement the cortical, let's say the Sylvian Fisher, to look at more carefully too. But I learned today also it's important to implement also the anterior complex to see any asymmetry and to compare the anterior part of the brain to the posterior part of the brain. So if you have any ventricle size of some 7 to 8 millimeters, not the one, 12 millimeters are already abnormal, but 7 to 8 millimeter, look at the anterior part. Do you have anything additional? Is there a need then to switch to go transvaginal? And if you are scanning transvaginal, as Sritsoko is suggesting, you have an excellent possibility to compare two hemispheres. If you are scanning abdominally, the proximal one is hiding. So this is why to the question asked, is it easy? If you don't have additional hint, no. But if you are looking to if you add to your checklist, the Sylvian Fisher, the shape of the CSP and the asymmetry of the brain, the anterior to posterior comparison, then you may discover these things. This is my comment. And for you, Nina, you give me now an idea for a new talk. We could call it one day, the face predicts the brain, not only on holoprosencephaly.
Thank you very much, Ravi. Okay, so now let's move on. The next question. Should we measure the corpus callosum routinely?
Can I add something?
Okay.
Rutsiko.
Yeah.
I think if at all you are evaluating anterior complex, it's a one good volume will add a lot of information to your fetal CNS. If you have got one good volume imaging of anterior complex, it will add on a lot of information. So I feel, what is your comment on this 3D of brain and utilizing anterior complex evaluation? Ravi, your comments, and Rutsiko, your comments also.
Ravi?
Yeah, so I learned from Ritsuko, if I'm scanning transvaginally today, tomorrow, I'm always acquiring volumes, because especially if you want to compare left-right, you may be very oblique if you are looking to 2D. Because, if you think one hemisphere is larger than the other, and so on, if you have a standardized approach, you don't need to scan longer. You can have several volumes. Later on, you can have a look here and there. And this is what I changed today in my daily work.
Oh, actually, that I do always taking the 3D volume for any kinds of brain, normal or abnormal. So, but that I learned from the cases that the very subtle abnormality can be detected by the 3D. That after the rotation and the looking at the the tomographic ultrasound imaging. So I think of course I do 2D scan, and then I look at I took the volume later on. So, that is much more helpful for the offline analysis. Is that okay, Prashant?
That's it, but especially with early brain, when you try to evaluate from 14-week to 24-week, I think ultrasound and 3D ultrasound is probably better than MRI, if I'm not wrong.
Yeah, of course. In early pregnancy, before 16 weeks of gestation, there is much better, the 3D ultrasound, or even the 2D ultrasound is much better than taking MRI. The MRI, it is quite difficult, to take 16, 14 weeks baby, right? Okay, shall we? Okay.
Can I make an observation?
Something.
If you just very, very careful with 3D volumes, because if the patient breathes in the middle, sometimes you have a very tiny irregularity, and then you think you have heterotopia, whatever. We have fallen there. So check also in the cortex, then outside and everywhere else, then you can have this movement because it's tricky. And sometimes it's a problem. And also I think for the lamination analysis, sometimes the quality of the acquired volume may be questionable. So always, if you suspect an abnormality of the lamination in the volume, go to the 2D and compare. We have done it with our latest Voluson, and we see very interesting findings. So whenever you suspect on a volume, I think for the lamination, check in the 2D scan.
Yeah.
I have a question for Gustavo, because when you were saying the size matters, I wanted always to ask you this question about macrocephaly. When you see macrocephaly, what is the role of the subarachnoid space? Because you may have large BPD or large head circumference, but the brain size is normal, and sometimes you have some enlarged subarachnoid space, which could be rather the kind of where the father has this. Or sometimes if it's, let's say, symmetric as usual, then the brain is also big. So do you know, or do you have experience, or let's say more empiric experience, if this plays a role? You say macrocephaly with large subarachnoid is for me rather normal, but if it has its all symmetric normal, it means the brain is large, so macroencephaly. Is there any data to this?
Yeah, for years the neurosurgeons were speaking about they call arrested hydrocephalus, or they have a lot of names for these cases. Even they used to perform surgeries that today is quite clear that is not necessary. So you have a child or a fetus that have a very large head. The head circumference is very large, okay, and there is a lot of fluid around, okay. Usually it will be okay. The problem is when you have a head that is small or normal and a lot of fluid around. And this means that you have microencephaly. So the problem is more common there, that you see normal head circumference but small with a lot of fluid around. Those are the cases that I am truly worried. But again, when we speak about macrocephaly as a synonymous of megalencephaly, we accept that we are not speaking about fetuses that have hydrocephalus, ventriculomegaly, or very large subarachnoid spaces. The other problem with subarachnoid spaces is come when you perform MRI, because when you perform MRI and there is a lot of fluid around the brain, the radiologist needs to be aware of that, and that the fact that the sulci are more pronounced. And we have a lot of discussions regarding these facts. So another important thing is that we published years ago in 2001 a paper where we measured the size of the subarachnoid space. And if you measure it in a coronal plane at the level of the foramen of Monroe, it should be not bigger than 5 millimeters.
I know. I cited your paper. Unfortunately, you cannot come to FMF.
No, I still
The sinocortical and the craniocortical. But today we see the perisylvian, and there are no measurements done because, if you go vaginally, don't have a clear part to measure. For abdominal, there are some paper measures. So, but I want to know more your empiric feelings, so it doesn't play a role, or you look at it when you have macrocephaly. Thank you.
Thank you. Thank you. Shall we go move to the next question? The
Happiness lecture.
honey?
We're in time?
I'm not sure.
Actually, we are running little late. So we will cut short those question and answers. So I think if at all,
Okay,
it
so
should be presented first, and then, if possible,
okay.
or you may keep. You may have some 2 or 3 or 4 good questions. You select, and then you can go.
Okay, so actually, some of the participants, they don't know, they don't understand the shape 8-shaped brain. So would you please explain about?
Can I share it again?
Yeah, if
Yes.
possible, it is, yeah. So
Yes, so I will share it again.
what is 8?
Okay. Yes, okay, this is good. In fact, I had the number 8 printed on and I have erased. Now I understood that didactically it was wrong.
So many of the people, the participants,
Actually,
It should say figure 5.
toast shape brain. This is Daniela's.
Yes.
yeah, toast brain. This is 8.
Do you see?
Yes.
Do you see the slide? Okay, so normally I will do something else. I will go back to Ritsuko's here. So you see, guys, that even after 21 weeks in CoronaView, but especially after 23 to 24, so we need to have a sharp angle, 90 degrees. So we have the frontal lobes, and then we have the Sylvian fissure quite marked in a square shape indentation here. Whenever we have 17, 18 weeks, so we have the round shape. So this would be like the 8-shaped brain. Okay, like a round and round. And here we shall have normally this marked separation, and after 23, it should have a 90 degrees angle. So, and here we have what we have called the toast. So the toast, like the upper portion is smooth and does not make the round, and the lower portion is developed. So here I will show you again in postnatal literature. So this is list 1. So we have like the 8 shape. This is the classic shape of list 1 in postnatal literature. And what happens in the fetal life is that, let's check where I am again here, that we can have different diseases that will have quite a like pattern. And the one that I saw that it's the most 8-shaped brain, and I was sure that this fetus was list 1. It was not even a classic lysencephalic gene, but this is list 1, and this is the shape that they tell. So what is important is the shape of the Sylvian fissure that is quite delayed, abnormal, aberrant in these fetuses. Hope it has explained.
Yeah, most probably that they can understand. Thank you very much. And Gustavo, do you explain about the polymicrogyria, which is very obvious, in the brain, by neurosonography or neuroimaging, but sometimes it is very, very difficult to see the histologic polymicrogyria. And you explained about that, the very shortly. So would you please, explain more about the difference between the histological polymicrogyria and neuroimaging polymicrogyria?
Okay. from the histological point of view, polymicrogyria is the presence of abnormal many small gyri that are not covered by meninges. Okay, they look like a gyrus, but the normal gyrus are covered by meninges. The sulci, inside the sulci, they need to be covered by meninges. From the pathological point of view, polymicrogyria means sulci, that they look like sulci, but they don't have meninges inside. From the imaging point of view, we call polymicrogyria everything that is different, where you see difference in the shape of the sulci and gyri. You have more than usual, smaller than usual, but this is quite clear when there is a severe form, usually with associated malformations. But when you have normal lateral ventricles at 37 weeks or 35 weeks, the chances to make a diagnosis of polymicrogyria is difficult. And we have shown that it's also difficult by MR. We have a very, very sad case where at 27 weeks, the MR was considered normal, and the child was born with very severe polymicrogyria. So we are not good there. We are not enough good there. And when it's focal, we are even worse. So I don't pretend, and you must understand that the polymicrogyria is tricky. And again, I think that eventually, as I finish my lecture, if you want to have a good diagnosis, start by doing exomic sequencing, and there you are going to find many diseases that are not present during fetal life or even during the first years of life. We are far away to reach 100% diagnosis of brain disease by ultrasound. If someone pretends that he is able to see everything, he is cheating or wrong.
Okay. Thank you very much. And we have more questions from the audience. However, we are running out of time. So can we go for the case conference session? Prashant, is that okay? So thank you very much for discussion. Maybe, after 3 cases from the Asian ladies, maybe, we can have the Q&A again. Okay, so please be staying here. Okay, so next are the 3 presentations from Asian ladies. And the first is the Dr. Nguyen. She is from Vietnam and currently served as the director of the Fetal Medicine Center at Tan Am General Hospital in Ho Chi Minh City. And she has a long-time experience of the fetal ultrasound in Vietnam. And the second one is Dr. Isabella Wall. She serves as the consultant and honorary associate professor at Prince Wales Hospital, Chinese University of Hong Kong, working for the brain clinic with Professor Leona Poon. And the third one is the Dr. Virada Deliafat from Thailand. The OBGYN department, maternal fetal medicine division of the Ramadibodi Hospital, Mahidol University, Bangkok. And she studied neurosonography in my institute, Osaka, Japan. So 3 of them are discussing about their rare cases. So from the first one, please. After 3 presentations, we will have the Q&A again. Okay, thank you.
Good morning, good afternoon, good evening, everyone. I'm Dr. Ha Tô Nghiên from Fetal Medicine Center of Tâm Anh General Hospital, Ho Chi Minh City, Vietnam. I would like to thank you, Professor Risikoku, for inviting me to join with this wonderful webinar. We had a fantastic lecture about MCD delivered by outstanding professor in this field. And now I would like to share with you an interesting case about tubulinopathy. Tubulinopathy comprises two distinct prenatal imaging partners. The severe form, usually characterized by enlarged germinal matrix, microdyscencephaly, and kinked brainstem, and the mild form usually present with non-specific features such as asymmetric brainstem, midline distortion, cochlear dysgenesis, distortion of cavum septum pellucidum, ventricular dilatation, delay of percolization of singular feature. And we report an affected fetus with mild form on ultrasound and MRI finding, and a variant in tubulin 2B3 on wet. A 27-year-old pregnant woman, first pregnancy, the combined test at 12 weeks were low risk for aneuploidy. The morphology scan at 22 weeks were normal too. She referred to our office at 28 weeks, and the biometry in normal range. The estimated fetal weight about 18%. In the ASEAN plan, we can see the asymmetric and borderline ventriculomegaly, with one side is about 8.2 millimeter and the other side is about 11.7 millimeter. In the sagittal plan, we can see the corpus callosum is thin and short. It's only 29 millimeter compared with a normal baby at 28 which should be about 34 millimeter. In the coronal view, we can see clearly the distortion of anterior part of interhemispheric feature, and the cavum septum pellucidum also distorted. The bilateral frontal horn dilated and had a square shape, and the symbiont feature sound very abnormal and asymmetric bilateral. She had an MRI at 25 weeks. In the MRI, you can see the distortion of anterior part of interhemispheric feature, the asymmetry of lateral ventricle, and dysgenesis of symbiont feature. She had amniocentesis and the karyotype normal, the CMA normal. However, the exome sequence were abnormal with a variant in tubu B3. We recommend the couple to have the exome sequence and MRI. However, they refused and they decide to continue pregnancy. To conclude, the prenatal diagnosis of mild form of tubulinopathy remains challenging due to subtle imaging findings in late gestational age. The midline abnormality represented the most common reason for reference, like in Hagigi study. And when this finding is suspected, a detailed neurosonographic MRI and then web should be indicated. Thank you for your listening and looking forward for further discussion. Thank you.
This is a 35-year-old lady in her first pregnancy. Her first trimester combined Down screening was low risk with a normal nucleotranslucency, and the non-invasive prenatal testing was low risk and showing a female fetus. Ultrasound at 18 weeks already showed there is a evidence of hydrocephalus, and this patient was referred to us at 20 weeks of gestation. This is the axial view showing bilateral severe hydrocephalus. and the transcerebellar view showed the transverse cerebellar diameter correspond to 18 weeks of gestation. Fetal morphology in older systems were all normal. In particular, there was no ectoderm, and this is a female fetus. This is the axial plane of the fetal brain. Besides the severe dilatation of bilateral lateral ventricle, the parenchyma was thinned, and the third ventricle was dilated, but the fourth ventricle remains normal. And on the sagittal plane, the midline structure could not be clearly seen. Therefore, we captured a 3D volume of the fetal head, so allow us to have a better appreciation of the midline structure. After capturing the volume, I straightened the brain by manipulating plane A, then I draw a line in the middle, so the reconstructed sagittal plane could be shown precisely. Then I slowly move the line to the side, so you can clearly appreciate the thinning of the parenchyma on both sides of the brain. So when I go back to the mid-sagittal plane, there is a thin corpus callosum and a dilated third ventricle. Then I capture another 3D volume in the sagittal plane. Then I swing the line from here, so can allow me to appreciate the coronal plane from the front and to the back. The inner hemispheric fissure is intact. But then here you can see that the cavum septum pellucidum was ruptured, and there is dilated foramen of Remoulin. We routinely measured bilateral silvian fissure angle in the clinic, and there was obvious delay in the development of bilateral silvian fissure. And this is the MRI of the fetal brain in the coronal plane from the front and to the back. And this is the sagittal plane. So this is the mid-cell section of the fetal brain. I think some of the experts here may already know the diagnosis after showing the MRI. So here you can see there is a brainstem kinking as compared to the normal reference. So to summarize the finding of this case, there is presence of severe hydrocephalus and a small transverse cerebellar diameter, and also a delayed silvian fissure development. And last but not least, there is kinking of brainstems. So amniocentesis was performed and a chromosomal microarray showing a negative result. And therefore we proceed with the whole genome. Then we proceed with the WGS showing the fetus is having a compound heterozygous pathogenic variance in the POMGNT1 gene, which is associated with muscular dystrophy, dystrophy. With the prenatal onset, it is associated with the most severe presentation, and it is also known as the Walker-Warburg syndrome. This case had terminal pregnancy performed, and thanks to all pathologists. For the brain dissection, besides a marked bilateral hydrocephalus, in the histology slide there is evidence of polymicrogyria, which is characterized by the undulating pattern of the cortical layers as indicated by the circle on the right-hand side. So the lesson to learn from this case is that in the case of severe hydrocephalus, besides looking at the hands and gender to exclude L1-CAM syndrome, we also have to pay attention to the brainstem, which could guide you to the diagnosis. Thank you for your attention.
Good evening. Firstly, I'd like to thank the Fetal Brain Society for giving me the opportunities to present our malformations of cortical development or MCD case. It's my honor and great pleasure. A 33 years old, 23 weeks and 3 day pregnant woman was referred to our hospital in January 2023 for suspect enlargement of the left ventricle's anterior horn. Ultrasound exam at 10, 14, and 19 weeks revealed no major anomalies, and the NIPT showed a male fetus with a low risk for common aneuploidies. Her last child, who is healthy, was born 2 years prior. The left image in the anterior coronal plane shows asymmetry. The left anterior horn is enlarged, square-shaped, and has an irregular lateral wall. Past the serial features are also asymmetrical, with the left side appearing shallower. The crease on the right scans from the anterior to posterior. Here show an enlarged left lateral ventricles. You can see several scattered nodules along the frontal horns and body of the ventricles protrude inward. In these parasagittal views, you can see both sides of lateral ventricles. The right lateral wall is smooth, while the left side is enlarged, bumpy with increased echogenicity, suggesting periventricular nodular heterotopia or PNH. We requested a fetal brain MRI to confirm the diagnosis. Picture 1 and 2 show axial views, and picture 3 show the coronal view. The left lateral ventricles has an irregular margins with small nodules along the wall, marked by the red arrows. This view also shows the asymmetry in the cortical surface. The right is smooth, but the left, shown by the blue arrows, is irregular. Picture 3 reveals the left ventricle is enlarged, with a small nodule protruding into the lumen. The green arrows point to the serial features, which is shallower on the left. As a result, unilateral PNH with abnormal left cortical surface is suspected. Our diagnosis is PNH with an abnormal left cortical surface at 23 weeks and 3 days. Let me briefly summarize the key findings on this slide. Enlarged square shape, irregular lateral wall, nodule protrude inward, irregular cortical surface, and shallower left serial feature. So what did we do? We talk about the fetal brain finding to predict the postnatal outcome. Key factors include severities, fetal gender, and genetics. The main worry is that 70 to 80% of cases will develop epilepsy, which can start anytime from birth to adulthood. Most will have severe drug-resistant epilepsy, needing targeted treatments. Since PNH are deep in the brain, surgery is risky. For example, removing a nodule in the occipital horn could affect vision. The severities also depends on the baby genders and genetic test results. PNH is often caused by a defect in the vitamin A or FLNA gene, inherited in an X-linked dominant way. Since this case is male, it usually indicates a more severe condition. We also discussed about her genetic testing and the chance of recurrence in future pregnancies. In Thailand, abortion is allowed up to 24 weeks. So after consulting with specialists, the parents decided to terminate the pregnancy and do further genetic testing, including exome sequencing. Here's a gross examination of the fetal brain after termination. Picture 1 and 2, you can see the difference in the cerebral surface. The left side is more mature than expectation for the gestational age. And here, an irregular cortical surface in the pericemial area, while the right side is covered by subdural hemorrhage and shows less outside and giant line formation. Picture 3 shows a coronal section of the frontal lobes with nodules, these pink arrows, along the left lateral ventricles. A microscopic examination was done to check the abnormal finding from gross examination. The upper image shows many normal baby neurons remaining in the ventricular zone and forming nodules along the ventricular surface. Here, instead of migrating up to the cortical plate, as they normally would. The lower image shows area with extra small folds called polymicrogyria or PMG. Genetic tests, karyotype and SNP array from cord buds show a normal male fetus. Exome sequencing found an FLNA gene variant inherited from his mother, but it's benign or likely benign variants, so it doesn't explain the patient condition. Here are some key points from this case. The enlargement is in the anterior horn of the lateral ventricles, not the posterior horn, which could be missed on a standard OB scan. Number 2, this is a condition with PNH and PMG, which might lead to more severe issues. Number 3, FLNA variant found is benign, so it doesn't explain the brain anomaly. For her next pregnancy, the recurrence risk is unclear. If she tries again, we advise early, detailed ultrasound monitoring. Lastly, I'd like to thank the OBGYN department for all their support. Special thanks to Dr. Chayada, the primary physician, Dr. Patama for beautiful OB scan images. And I'm also grateful to Professor Poo for inspiring and guiding me into this field. That brings me to the end of my presentation. Thank you for your attention.
Thank you, guys. The excellent presentations from 3 countries. I was so moved that everybody is doing the very passion, the neurosonography, and very beautifully. So now the discussion. Would you please show up, 3 of you? Nguyen and Isabella and Virada. And is there any questions from the faculty?
Yes. Okay.
Yes.
I will start asking for the case with the 2BB3.
The first one.
Did you perform a fetal and an MRI on the parents or trio exomics?
Sorry, we recommend, however, the parent refused.
Oh.
Yeah, this is the first baby, and
So-
they
The exome, you didn't did a trio. You did only the exome of the fetus.
yes.
Oh, so it's not the trio. There is solo.
So you need to be aware when you give the genetic consultation that the chances that 2BB3 is from one of the parents are quite high. So and in these cases, the prognosis can be good. So you need to ask for a very good neurological examination of the parents, to perform an MRI of the brain MRI of the parents, or to do an exome of the parents, because if one of the parents is a carrier or is affected, it's not a carrier, it's affected because it's an autosomal dominant disease, the chances that the next pregnancies will come with the same findings are 50%. And this is very important, and I am speaking based on my experience, that we have 2 cases where in the past we terminated pregnancies because of similar findings, and it turned out that the mother, in one case the mother, in another case the father, have the same disease. So the 3rd pregnancy with the same findings was conducted, and the child is born and is completely normal. They may have some learning problems or things like that. This is regarding the first case. Regarding the second case, the 3rd case with the periventricular nodular heterotopia, we have learned during the time that many cases that we used to classify or heterotopia or PMG, but as different disease. But we have found that many of our cases that are very severe have both. and this is a transparenchymal involvement. And in these cases, you don't expect to have a filamine disorder, but what is expected to have is a very serious condition. So you did well that you recommend termination. And in the middle case, my question will be, did you, in the case with Walker-Barbour-like syndrome, did you examine the eyes? Because usually in these cases, the eyes are also pathological. You will find or retinal detachment or some kind of eye finding. Muscular findings are not seen by ultrasound, but usually in these cases you will have also something in the eyes. And although it's very, you say, okay, it's Walker-Barbour, but also it can be Joubert. So you should be careful there. Those are my comments.
Okay, thank you very much, for your comments. And Yuan, maybe you will have a chance to take MRI of the parents, and also take their blood for the trio exome sequencing, right?
Yes, we learned from Malinger study, and we know that 2B3 may be the good prognostic and guess from the parent. So we asked them, however, difficult for them to have the MRI and exome sequence. And anyway, they would like to continue pregnancy, so they refuse to do. And we have follow up, and we'll let you know the outcome. Thank you.
Okay. So because that is a very, very mild case, right? Okay. So the second case, Isabella. Did you examine the eyes?
Well, we did a scan, so we routinely see the eyes, but then I did not pick up any abnormality on the eyes. And then our pathologist didn't do a dissection on the eyes as well. Yeah, so I'm not sure.
You did the autopsy, right?
Yeah, but then we didn't cut the eyes.
Okay. So, all right. So, but the findings of the eyes is one of the points in the case. And the third case, Virada. So, you showed us the very, very big heterotopia, right? So there is the one of the audience asked that is that the heterotopia or hemorrhage? Do you think that that is a heterotopia?
Yes, right. We think that on the left lateral ventricle, that is the heterotopia. Yes, and we confirm by the gross examination and microscopic examination. And as you see, the hemorrhage is on the right side. It's opposite, another way.
But the zone that you show as heterotopia, I think that actually you are showing the ganglionic eminence that is very rich in neurons and at this stage of age. So the heterotopias should not be there. Should be more laterally in the lateral ventricle. But what you show very nicely is the polymicrogyria. The pathology of polymicrogyria is nice. But this very, very blue zone is the ganglionic eminence, in my opinion.
Oh, but what do you think, Virada? Is that the place for the ganglionic eminence, or you think is that the outside lateral ventricle, right, or inside? I think the ganglionic eminence is below the lateral ventricle. So if it is a ganglionic eminence, maybe the place you took
the amount
tissue.
Okay. But
you're so big, right? It was so big, and usually the heterotopia, the lateral, the heterotopia is like this, right? So, Ravi, do you have any questions?
No, my tip to Virada. Have you heard this session from this morning? You were there?
Yes, right.
So what you should do actually in such a case, if I was you, because you don't have an explanation, ask the geneticist to perform exome on this part of the brain. Because we heard today that you may have mosaicism. If you have asymmetry, it's not tubulinopathy. You have one brain look like the other one different. And this is, I think, the next part where we may find mosaicism in some part of the brain explaining this thing. Why not? Could be.
Yeah.
Yes, Professor. Indeed, we did the brain, the tissue biopsy to rule out the somatic mutation as well, and the region is only the FLNA1 benign variants. Also,
Wow.
You did that.
yes, yes.
Only the finding was the filament A.
Yes, it's the same from the Codman.
Okay. So Karina.
Okay, first I want to congratulate you for the presentation because it was very, very, very nice. I think it was very high quality, and it's amazing to see that you are doing such a great job in many other places. So really, I congratulate you. And some observations and questions. First, I think what is very important from the TUBB3 is regarding what Gustavo said, and I think regarding malformations of cortical development. There are some malformations that they look not nice in imaging, and they are quite frightening, and not necessarily the translation of the clinical prognosis is bad. So we need to be aware of this. That this is the importance to have the genetic confirmation whenever we can, and to have the multidisciplinary team. So to have the pediatric neurologist, the geneticist, the radiologist, and us, and the pathologist working together, because this will be the best way that we give the best prognostication and help these families. That we have the publication on the TUBB3, that it was very interesting case because the first child was already 9 and she was diagnosed like perinatal asphyxia, and that she has cerebral palsy. This is first child. Then the fetus with the TUBB3 features was then terminated before we understood what it meant, because it looked like a severe or a diffuse brain compromise. And then when the third pregnancy came and we have the same pattern in the second fetus, then we said, okay, let's send the mother to MR. And then we invited the first child, and then we saw that everybody has the same pattern. The first child had a worse phenotype, and then she had these features that was all the time. The square-shaped anterior horn was considered post-ischemic changes of the brain, and they did not even do a genetic investigation, and she was mildly affected, let's say. And then after that, we could understand the family tree and the prognosis. So these autosomal dominant abnormalities, sometimes they have different presentations, and we need to be aware that if imaging looks very bad, not necessarily the clinical translation is bad, specifically speaking on tubulinopathy. So I think it's really very important that the patient have these comprehensive counseling on this type of a case. Regarding the cobblestone malformation, I'm happy that you brought it because we didn't have time to discuss it and to show the differential diagnosis with other types of smooth cortex. And I think it's it is indeed a case that our guess on the gene is good, especially when we see the association of the Z-shaped brainstem and the other findings. And the importance on the counseling for these patients. Many times they have very early hydrocephalus. You send the patient to curettage. You don't do genetic investigation, and then they have a 25% risk of recurrence. So it's very important to send early hydrocephalus to investigate. And regarding the last case, my question is, did you consider to reclassify the filamine variant that you found? And together with the question, it comes a hint. We need to understand that the fetal phenotypes of the MCDs are not well established. And we need to help the HPO terms and to help the geneticists to establish the fetal phenotypes of the finding. So one thing that we do in our place a lot is to check on the variant, on deep in the specific variant, and sometimes then we send to the ClinVar and to other databases that this variant can present with a pathologic phenotype as well. And it helps the database of the geneticists to stratify better the abnormalities. So it's our task in the fetus to send and to feed these databases because they are very poor with fetal phenotypes. So if you did consider to reclassify, and if not, maybe you should.
Thank you, Karina. That is a very, very difficult issue. Because that this MCD is not established completely, and now that we have the Professor Richard Reventhal. He just joined us. You should please show up.
Ruchiko, can I comment something about how after the abortus, if you want to see the eyeball, simple apply 11L.
Sorry, Prashant. The internet is a little bit unstable, and we cannot hear. What did you say?
If eyeball after the in abortus, we use 11L probe ultrasound to evaluate the eye after the abortion. That is going to be the one of the system which we are using. If you
Sorry, Prashant, the most probably, your internet is very unstable and we cannot hear your voice. And hello, Richard. Thank you very much for joining us.
Hello, sorry I couldn't join the rest of the webinar.
Thank you very much. Your lecture was beautiful and wonderful. And actually, we learned a lot from you about especially the somatic mutation and others. And Gustavo, Karina, do you have any comments or the discussion with the Richard?
First, I am a fan, Richard. Sorry that I do it in public, but I am. I really am. And I learned from you a lot, also from your publications and when you were here. And I remember you did us a quiz and showed us many, many postnatal patterns. And you make me envy the pediatric radiologist every day because you have myelin and you have the final phenotypes. So we learned from you a lot. And thank you for your brilliant lectures. I have no specific question, but you just summarize how complex it can be and what are the newest advances. So we will keep on checking on your publications and the new things that you have to show us.
Thank you. I think I have a much easier job, as you mentioned, looking at a baby that's already been born that I can examine and a scan that's the child is not moving and, as you mentioned, myelination taking place. So I think you guys have a much harder job than I do.
Gustavo.
Thank you for the lecture. Thank you mainly for being with us to accept our invitation, because one of our goals is to bring people from other specialties, not only obstetricians, to the society. And You were invited to the Congress, but this time you were in vacations in Europe last year. And I hope you will come to our next Congress that will be in January 2026. And what is important, we need to try to motivate you to help us with the diagnosis based on images that we have, because your understanding is much better than ours because of the experience with children. So thank you for being with us.
Thank you. I hope I can join you.
Yeah, actually, we have always, they're looking at the fetuses during the pregnancy, the very early pregnancy till the late pregnancy. And sometimes, that we found the very rare and it is questionable, that is abnormal or normal. And so I think, that we need the knowledge from genetics and also, the pediatrics and the pediatric the imaging. So we learned a lot from you, and thank you very much. And here, Ravi Chawi from Germany. Ravi, do you have any comments?
I like very much your talk as the other, Rick. And while I was watching this, I was wondering whether you, in some selective cases, is there indication of doing brain biopsy, or one day we may ask people to do a fetal brain biopsy. Is it something where it is considered today or not yet? Because you cannot wait until there is a partial hemispherotomy and then to get this material. So is it something which could one day be available, especially when we know that for mTOR there are some treatment before starting with everolimus treatment, if there is anyone did it or thought of this?
I think people have thought of things like brain biopsy. There's a few comments. So sometimes epilepsy surgery is done in 2 stages, where electrodes are put into the brain a week before the resection, and then they stimulate different areas and record from different areas. And now this is published, people have actually extracted DNA from those electrodes. They haven't actually used that yet in terms of guiding what sort of procedures done, but theoretically you can actually do the genetic testing in that week between when the electrodes go in and when you plan your surgery. That's not really a biopsy as such, but it is a way of getting DNA in advance of doing epilepsy surgery. Another thing people are looking at is making a diagnosis from CSF.
Yeah, this was my next question.
So that's a little difficult because at the moment you can't really do broad genomic testing from CSF, such as an exome. You need to know what mutation you're looking for, but there are, with mTOR, for example, there's 5 common pathogenic variants or mutations for the mTOR gene causing cortical dysplasia. And lastly, you mentioned mTOR inhibitors. Yeah, it'd be great if they worked, but they don't work terribly well for the epilepsy. And that's because they're not going to take away the malformation or the dysmorphic neurons. They might help a little bit with the epileptogenesis, so we still need better treatments. There was a paper a few months ago from the Bolac group in France about a very interesting treatment, non-surgical treatment, which they call a molecular scalpel, using things called senescent treatments. I think it was in Nature Neuroscience. It'd be worth looking at that. That's an exciting way potentially of dealing with dysmorphic neurons with a medication. Okay. I meant to say, I picked up on something that you said, Karina, that I strongly agree with. That cortical malformations can sometimes look terrible on a scan. But when the baby's actually born and you know what type it is and what the gene is, you can be much more positive about the prognosis. We wrote a paper illustrating this a few years ago on Chudley-McCulloch syndrome as an example of a disorder that looks absolutely terrible when you see the MRI, and the children, apart from having deafness and mild or no developmental delays, actually do very, very well. And that's an example of where the genetic diagnosis is so critical. So I joined you just as that presentation was ending. Sorry, I had other commitments today, but I heard a lot of the discussion after that, and I picked up on what you said, Karina, about how the scans can often look a lot worse than the outcome's going to be.
Thank you very much. Maybe if we can do the CSF examination from the cortical malformation cases, we can extend something, in the fetal field. But maybe because of the small amount of the DNA or the small amount of the cells containing the mosaicism or something, that maybe it is difficult. Richard.
Yeah, I think I mentioned that in my talk, that it's very difficult to find these very low-level mosaic cases. You need the right tissue. You might even need the right cells within the tissue in the case of dysmorphic neurons. And then you need to do very deep sequencing techniques. And none of that is available in clinical labs. It's all in the research realm at the moment.
Okay, thank you very much. Karina?
I found a question in the end. Rick, do you perform any other laboratorial assessment in patients with polymicrogyria whenever you rule out a genetic cause? Because, I see many of the pediatric neurologists, sometimes they treat the child and the family does not receive the proper counseling regarding risk of recurrence. As well, in pregnancy, we are always thinking about the chances that things will recur, and we need to advise for further pregnancies. So we try to. I have like my clinic where I do the puzzle settle when I take all the aspects and I try to recommend what to do regarding further pregnancies. And in cases of PMG, because we know that many times it's not genetic, and if we rule CMV or other things, we get a little stuck. So I wanted to know if you do any other investigation in order to understand why did it happen.
We also get a little stuck. I don't think it's unique to fetal, because PMG, despite being so common, we understand so little about it. So the standard thing is we get out the Guthrie card and do CMV PCR, and we do an array looking particularly 22q and 1p36. There are other deletions associated with PMG. And then ideally you do a trio exome. But beyond that, there's not much more we can do for PMG. And with all that, chances of making a diagnosis are no better than about 30%.
Okay, thanks.
Hey, thank you very much for the discussion. And so we will move on to the next educational lectures. The professor, Dr. Daniela Prayer, was head of the research institution division of the neuroradiology and musculoskeletal radiology at the Department of the Biological Imaging and Image-Guided Therapy at the Medical University, Vienna. And she has a lot of experience with the fetal brain MRI. So the Professor Daniela Prayer, please start your lecture.
Thank Thank you, Ritsuko, for inviting me to talk about MR imaging of fetal MCD. Recently, a new classification has been published to classify prenatal MCDs as they appear on MRI images. And as you can see, what has to be taken into account here is laterality of the lesion, whether it's bilateral or unilateral, symmetry, whether it's asymmetric or symmetric, and then a classification was done with the morphological description. It was seen that MCDs are more frequent in male fetuses, more frequent when the brain is small, and more than 50% of the disorders were associated with problems of commiseration. The problem is we still do not know what features can you see in the second trimester and which ones in the third trimester. And is it really true that a reliable diagnosis of lissencephaly is not possible before gestational week 27? Well, what can be the underlying background of an MCD? There are, of course, genetic mutations. They can cause impairment of cell proliferation, migration, and post-migrational maturation, leading to all these pictures we know from images late in pregnancy, ultrasound or MRI, or postnatal images. But exactly the same changes may be a consequence of infection, of toxic events, or vascular events. So what we want to know is the background of such a malformation a genetic one? Well, mutations in one gene may cause different malformations, and mutations in two or more different genes may cause one and the same malformation. So what we want to know is there a genetic background, or is there a background of an acquired malformation? And we have some morphological signs that may point towards an acquired background. These signs are hemorrhagic residuals, twin pregnancy, or additional other signs outside of the brain of fetal placental malperfusion. Maybe there is a history of an environmental insult, such as, for instance, an infection, or schizencephaly, which may more often be acquired than has a genetic background. Why do we have to make this differentiation prenatally if possible? Because postnatally, neuroimaging may less be able to distinguish genetic from non-genetic causes. Let's start with the hemorrhagic residuals. Here you have two different cases. First one is stage 30 of a 14-year-old mother, and you can see on the diffusion the residuals of an ischemic infarction, still bright on the diffusion-weighted images. You see hemorrhagic residuals here indicated by the yellow arrows. The second case is stage 31, a 16-year-old mother, shows bilateral infarctions. Well, you might call that hydranencephaly. And if it is survived, it might end up as either porcephalic defects or, if lined by gray matter, schizencephalic clefts. The next risk is twin pregnancy, because we know there is a huge percentage of defective vasculogenesis, thrombosis, and emboli. Very often we see polymicrogyria bilaterally or unilaterally, but also subcortical heterotopia and periventricular heterotopia. In this study, 61% of acquired brain pathology was MCD. The others were, as you see, cerebellar hypoplasia or other brain disruptions. Let me show you an example. These This was a twin pregnancy where both twins had polymicrogyria. As you see, twin fetus 1 on the left side of the brain and fetus 2 on the right side of the brain. And if we look at the placenta in this so-called echoplanar sequence, you see huge venous congestion, but in one twin with the blue arrow on the right side of the image, you see there is also venous congestion of the penetrating vessels on the side of the hemisphere where the polymicrogyria was seen. Let's look at another case. Is this a focal cortical dysplasia? It looks like that. We saw this child at 4 years where it has a circumscribed region of pathological gyration, and with 2 years there were still the remnants of a schizencephalic cleft. But how did it begin? Well, it began in gestation week 23, 2 weeks after umbilical cord occlusion because of TTTS, and this is the surviving twin, showing a region of impairment of cortical maturation, very circumscribed region. And if you look at the same fetus at gestation week 29 and 32, then you see there is polymicrogyria. And if we want to go back to the same child, as I already showed you, with 4 years, it was not anymore recognizable that this was a schizencephalic cleft and a rather big region of polymicrogyria. What we know in the meantime is that schizencephalic clefts change their appearance not only prenatally, as you can see in the row above, but also postnatally. So if you image a child later on, a small region of something that you might interpret as focal cortical dysplasia may appear that originally was a large region of polymicrogyria and in most cases schizencephaly. As I already said, other manifestations of vascular disruption may be present in other regions of the body. In this case, schizencephalic clefts were combined with bowel atresia and microcolon, and the orange arrows point also towards placental hemorrhage. So the schizencephalic, if you see that, you know the schizencephalic clefts are most probably of vascular origin. And then there is, of course, something that we always consider and do tests. It is MCD as a consequence of infection, most frequently of CMV, and during the Zika time, we also had very often Zika as a reason for focal or for cortical dysplasia. The reason is that CMV and also Zika impairs the microvascular endothelium, and so this is also more or less a vascular origin of an MCD. And here we have an example of CMV where you see a combination of subependymal heterotopia with bilateral polymicrogyria, and of course there are also other signs such as pseudocysts of this CMV infection. The next case, in gestation 25, you see a huge malformation of the cortex with a thinned and calcified parenchyma pointing towards laminar necrosis. If you see cases like that, and you don't find the infection underlying region, it may be a mimic of an infection-based MCD. And here, for instance, we see an example of an Aicardi-Gouttière syndrome. This is a fetus in gestation week 24, where it is not yet obvious where the extent of this cortical malformation is not yet obvious. But when we look at this fetus in gestation 33,
then you see that the cortex is destructed and the non-destructed regions are polymicrogyric. Of course, there is also a widening of the ventricles and cerebellar impairment and calcification. Why you should think of Aicardi-Gouttiere or other so-called interferonopathies is that there is a therapy available because anti-interferon antibodies may stop this development. And that's why it is worth to think about that. But let's move now to the morphological signs that may point to a genetical background. There may be rather strong signs, such as gradients, premature gyri or dysgyria, persistence of transient structures, or other signs of a genetically determined syndrome, and of course, similar findings in relatives. Weaker signs are the presence of a dysplastic or hypoplastic brainstem, the shape of the brain, and symmetry or asymmetry. It depends. When we talk about gradients, then we talk about occipital predominant or frontal predominant shapes. As you can see, either the posterior brain is lysencephalic and in the front you have some gyri, or it is the other way around. Unfortunately, it has been found that radiological findings could only reliably predict the molecular results with a posterior to anterior gradient, as you see in this example on the right side. The other gradients only point towards a possible genetic background, but you still have to consider a lot of genes that may be there with this gradient, and here you have another example. A better sign are the premature abnormal gyri. If you see already gyration at an age where no gyration should be present, as you see on the left side, gestation week 22, gestation week 25, and in the middle, there is the outcome. It is a muscle eye brain disease with polymicrogyria and, of course, with a very pathological brainstem that could be seen already in earlier stages. On the right side, you have an example of an unpair where you have already strange gyri in gestation week 24 and in gestation week 30, you have polymicrogyria. And of course, if you look more closely, I will talk about that a bit later, you have persistent ganglionic eminences that should be not there in that size in gestation week 30. When you have premature abnormal gyri, that you think of FGF mutation, you can have even gyri in the temporal and posterior regions at gestation week 17 or even earlier, and this allows to recognize these FGF mutations at a very early stage where you might not have other signs of these diseases. Dysgyria, what does it mean? It means strange gyri or an abnormal pattern not fitting in a category. Also, there can be an abnormal arrangement of gyri and sulci. Here you have very subtle signs of a sagittalization of the collateral sulcus, and this may also be a sign of FGF3 mutations, especially as in this case in chondrodysplasia, where all the other signs of abnormal cortical bulging may be absent. But let's now move towards the persistence of transient structures. Here you see a persistence of the germinal matrix. In the upper row of the fetuses, in the lower row, you have normal fetuses of the same age. And here another example where we can really see in the lower row this very, very big germinal matrices that are
in an otherwise lysencephalic brain. Then you can have also lesions in the germinal matrix, in the ganglionic eminences, and there are 3 beautiful papers from Regini where you can see the ganglionic eminence anomalies that they also later are associated with specific neurodevelopmental anomalies. And here we see an example of cavitation in a case of a metabolic disease, in this case, pyruvate dehydrogenase deficiency. And another example would be this. We perform 3D volumetry of the ganglionic eminences and have terminal values. And you can see in the lower row, these ganglionic eminences are too small because this is a gene mutation associated with mitochondriopathy. What about the dysplastic brainstem? The dysplastic brainstem is always a really strong sign that something is going wrong, and you can see it in the upper row compared with the normal fetuses in the lower row, and it is a persistence of the embryonic shape of the brainstem. And a flat pons that is not really dysplastic but also flat is usually a sign of the presence of a tubulinopathy. What about symmetry? Well, symmetry may be present as in lysencephaly 1, in cobblestone cortex, in X-like lysencephaly, but it is absent in Aicardi. Well, Aicardi, you will say we don't know whether there is a genetic background, but the presence of one is strongly suspected. And of course, also in hemimegalencephaly, where we know there is a genetic background, these morphological changes are asymmetrical. Let's move to the brain shape. Some years ago, we found that this flat brain that we call toast brain, where the insular indentation is too flat and the temporal lobes are wider than the frontal lobes, may be a strong sign of a genetically determined malformation of cortical development. And of course, this has already been described in literature. Other signs of a genetically determined syndrome, what we see here is, in addition to an abnormal cortex, you have the pathological brainstem and the delineation of the internal capsule that you see perfectly in the case in the blue frame is missing in this example of type 2 tubulinopathy. Here is another example. We have a lysencephaly with the gradient. The frontal cortex is smooth, the posterior cortex not. The corpus callosum is missing, and there is pontocerebellar hypoplasia. And of course, we thought of type 2 tubulinopathy, but this was not the case. We needed another pregnancy to make the diagnosis. This was VT syndrome, a syndrome that is also associated with extracerebral anomalies and with some anomalies that only can be seen postnatally. And here, this would also be an example of similar finding in relatives as the first fetus had already the signs we see in this second pregnancy. But maybe a better example of similar findings in relatives is, of course, the filamine gene mutation leading to subependymal heterotopia, sometimes associated with megacisterna magna, sometimes not. And as you can see here, the megacisterna was pregnant in both fetuses, but not in the mother. And MRI allows you to examine the mother right after the fetus, and that really sometimes help with your diagnosis of a genetic mutation that is also present in the fetus. So, MR imaging of fetal MCD There are morphological signs that may allow you to differentiate between acquired and genetical etiology. However, in case of hemorrhage, you also have to think of a genetic background, but a different one than usually in MCDs. You have to think about collagen gene abnormalities. And as I could show, I hope so, prenatal imaging is important to identify the original morphology of an MCD, as it may change later and look completely different than prenatally. Thank you very much for your kind attention.
Thank you very much. And the last one is my talk. And I because of the time, I reduce many of the slides. So I will present the only the 10 minutes. I will try. And so can you see my slides? Just a moment. My talk is about how to diagnose critical disorders in mid gestation, and actually the Gustavo and Tari proposed the 10 points in a practical prenatal approach to MCD, including MRI, transvaginal and transabdominal neurosonography. Of course, MRI is a strong modality, but we need to make diagnosis or have suspicion of MCD during our routine clinical practice. But it is quite difficult, especially in the mid gestation. The brain is very, very smooth. Brain surface is smooth, and no gellification almost yet. So, how to suspect the mid MCD in mid gestation, and maybe the some of the presentation already show the ventriculomegaly. However, sometimes the ventriculomegaly is not often showing up. It is very mild or absent in MCD cases. And also, already Gustavo told about the macrocephaly and microcephaly, and brain size is very, very important. And also abnormal gyri outside. This is only here. The very abnormal gyrification. In this picture, the ultrasound and MRI, and sometimes here this is abnormal RE gyrification at 20 weeks of gestation. This is a P10, the variant of the paternal UPD. Now, the lateral ventricular irregularity, sometimes those are 3 cases of the irregular ventricular wall, 24 weeks, 19 weeks, and 20 weeks of gestation. You can see this is exactly the periventricular heterotopia. And sometimes, that we see that this kind of the irregularity of the ventricular wall. And here, this is a question, is this just the lateral ventricular asymmetry? And here, this is 18 weeks and 20 and 23 weeks of gestation. You can see the very, very, the asymmetrical structure of the anterior bone. However, something here is I concerned. Here, this is the 18 plus 6, and you can see this is a wedge of the lateral ventricular wall. And then after that, 20 weeks and 20 plus 6, you can see this is much sharper the week by week. And then after that, 23 weeks, they're very sharp. But thereafter, 25 and 27 weeks of gestation, it is the much flatter and flatter. And here, the 33 weeks of gestation, almost flat. So the term delivery with a favorable outcome, and prognosis at 1 postnatal year in this case. And we have 2 more similar cases, but the cause is unclear. So sometimes it happens. So if you have the very subtle abnormality, don't think that the termination of the pregnancy. Maybe that you can examine, and the longitudinal study of the scanning is very, very important. Now about the irregular brain surface. Here, this is the macrocephaly with irregular brain surface in the ultrasound and MRI. And here you can see this is the MRI, and you can see the very irregular brain surface of the Sylvian fissure. And also here you can see, and this part is very very smooth. And this case was the AKT3 variant. And this is a postnatal MRI, and you can see the asymmetrical abnormal gyrification in postnatal MRI. Now, the brain is asymmetry, and this is 21 weeks of gestation, asymmetrical brain with ventriculomegaly. And this is the autopsy finding, and you can see the very smooth surface of the brain. However, here you can see this is a bigger brain surface, and you can see it seems to be the smooth brain surface. However, histological polymicrogyria is like this. So maybe we discussed already about the histological polymicrogyria with Gustavo. So sometimes the histologically it is the polymicrogyria. However, even you can see the microscopic finding. You can see the surface is very smooth. So it happens. So we can keep in mind to have the polymicrogyria histologically and polymicrogyria in the neural imaging. Now, the indirect signs of the MCD, and we talked several times. I talked about the Sylvian fissure and the medullary veins, Cattier line, and the abnormal GE. But today I would like to put the 2 points. The first, Sylvian fissure. Sylvian fissure observation may be significantly helpful. Already we discussed, and the Nina already showed this. The Sylvian fissure is changing its appearance, and so we have as one of the quantitative analysis of the Sylvian fissure. So Sylvian fissure angle, the measurement. And this is the already published data, published article, and the steps for the SFA measurement. The first step is acquisition. The second step is set the consistent plane, and the third was measurement. So the first step, the 3D neurosonography acquisition via anterior fontanelle. This is very, very important to see. And this is 18, 20, 22, 25, 28, and 30 weeks of gestation. As you can see, the Sylvian fissure is very the changing its appearance. So this is the 20 weeks routine neurosonography, in my clinic. And this is a step 2 and 3. And here you can see, this is the plane A, this is the coronal, and this is the plane B, the sagittal. And if you would put here, in the frontal plane, the plane A is like this. And then I put the line, the first line and second line here, on the upper edge of the Sylvian fissure, upper edge of the Sylvian fissure. And then the left side, you can see the left brain, you can see the angle is here. So after that, I always look at the forebrain in the tomographic ultrasound in the coronal and sagittal section. And this is 28 weeks of gestation, almost the same thing. And we can measure the Sylvian fissure angle, and before 25 weeks of gestation, the positive angle, but after that, negative angle. And usually many of the MCD cases, they have the much larger SFA Sylvian Fisher angle than the normal reference. So this is the de novo, the microdeletion, and here you can see that this is the Sylvian Fisher angle graph, and this is also the 11.6 mega base pair, the dilation of the 4p, and like this, and sometimes we cannot find the exome sequence negative data, but the postnatally this case had the epilepsy, and here this is the case at 19 weeks of gestation, almost normal looking, normal appearance of the brain. However, we look at the fetal face, micrognathia, loss at ear, and so I measure the Sylvian Fisher is almost good. However, after that, week by week, you can see this is a normal Sylvian Fisher in the lower row, but here you can see the almost the no changing of the Sylvian Fisher angle, and this is a FOXC2 gene variant. So it happens. So it is quite difficult, quite important to measure the longitudinally. And this one, 26 weeks microcephaly, the BPD was minus 3.3 standard deviation. And here you can see the angle is very, very abnormal. And week by week, the no change. And here you can see the Sylvian Fisher is like this. And this is a BAB1B gene variant, compound heterozygous inheritance. So the neurosonography transvaginal 3D is desirable because by transabdominal sonography, the distal Sylvian Fisher is blood, and by transvaginal neurosonography, you can see the bilateral Sylvian Fisher bilaterally, and also you can see sometimes it is asymmetrical structure of the Sylvian Fisher like this and like this. This is a double Sylvius, and also this is also the double Sylvius. So you can see this is a TUBB3 variant, and you can see the very asymmetrical Sylvian Fisher in this case also. Now, the last three, I would like to talk about the gangrenic eminence. Usually, the neuronal migration is like this. This is the excitatory neurons. However, from the gangrenic eminence, GABAergic, the interneuron is a connected neuron. This is born in gangrenic eminence, and to migrate this like this, tangentially migration occurred, and this is called as a connected neuron. And the gangrenic eminence is thinner and thinner week by week, during the pregnancy. And many of the several articles on abnormal gangrenic eminence in cases of the brain maldevelopment, and sometimes the persistent gangrenic eminence or cavitation or hemorrhagic change inside the persistent the gangrenic eminence. And here you can see this is by transvaginal neurosonography, normal gangrenic eminence, but at 14, 20, and 26 weeks of gestation. And here, the persistent gangrenic eminence at 18 weeks of gestation after the SIUD in monoclinic twin. And this is a monogenic disorder. You can see the persistent gangrenic eminence. And sometimes, the cavitation inside the persistent gangrenic eminence, here, at 19 weeks, 18 weeks, and 19 weeks of gestation. And then, this case, at 24 weeks of gestation, you can see the persistent, the gangrenic eminence. But later on, at 30 weeks of gestation, inside of the persistent gangrenic eminence, it might be the cavitation inside. So to recap, 80% of the neurons are excitatory neurons born in the ventricular zone and subventricular zone and migrating radially. However, 20% of the neurons are interneurons, and they are inhibitory neurons born in the ganglionic eminence and migrating tangentially. So this is my last slide, and how to suspect the MCD in mid-gestation. The many MCDs are detectable at mid-gestation, and Syrian fissures and ganglionic eminence should be observed carefully, and transvaginal neurosonography or MRI is a must, and longitudinal neurosonography follow-ups of changing appearance is very important. And of course, genetic investigation with and WGS is very, very important. Thank you very much. So, maybe we are running out of time. So I think if the speakers, if you have any comments at the last minute, please do. Ravi.
Perfect.
Thank
I want
you.
to listen to the seagull sign, but you was in Budapest or next
Yeah.
time.
Or next time. Yeah, seagull sign. The seagull sign is the mine and also the Birada's. So Birada is going to publish that with me. Okay, so please expect that. Now, so maybe that we have to finish. I'm very, very sorry because of that's my bad. There are many questions, but the one by one, I will answer that. As much as possible. And Karina, Gustavo, Ravi, is there any other comments? No.
Oh no, I don't think so. Apart of congratulating your amazing talk, and I'm happy that you had you got to address the ganglionic eminence, because we no one of us had the time to do that, and it's very, very important, especially for early pregnancy. So as a marker, even if you don't have the final diagnosis, I like to remember that sometimes those cavitations have been confounded to CPC, and people need to be very aware and not to confine the early cavitation of the ganglionic eminence to CPC, because then we may lose the opportunity to do the early diagnosis of abnormality. So thank you for your amazing slide.
Thank you very much. Thank you very much. Yeah, actually, it is very, very important, but it's very difficult to find that, as the ganglionic eminence, because the ganglionic eminence is not the on the coronal, anterior coronal section. So it is the broad to the posterior side. So it is very difficult. But Gustavo, do you have any comments or?
Yes. First of all, I want to congratulate you for the organization of this magnificent webinar, and particularly for the fact that you have the fantastic idea to invite young participants to present their cases. I think that this is fantastic, and I think that we need to keep this idea for further webinars to let